Good morning, sir. Once मैं दे रहा हूँ चेक करो आवाज आवाज एंड वीडियो ऑडियो क्लियर है ना चालू करू ना यस सर रिकॉर्डिंग We'll start with the CME webinar. Good morning, respected Dean Sir, Dr. Praveen Rathi Sir, Head of Department of Anatomy, Dr. K. Shyam Kishore Sir, all my respected teachers, seniors, students, and my dear colleagues. I, Dr. Nagaraj Pai, along with Dr. Shubhangi Mutyal, my Joint Organizing Secretary, welcome you all to the CME on Demystifying Embryology, which is being hosted by the Department of Anatomy at Topiwala National Medical College and BYL Nair Charitable Hospital, Mumbai. Demystifying Embryology was a dream of late Dr. Manu Kothari Sir, ex-professor and head, said GS Medical College and KM Hospital, and in his honor and memory, we have chosen this topic as the theme of this CME. Let us invoke Goddess Saraswati's blessings by a prayer rendered in the sweet and melodious voice of Dr. Sneha Sharma, postgraduate student in our department.
या कुंदे तुषारहार धवला या शुभ्र वस्त्रावृता या वीणा वरदं या श्वेत पद्मा या शंकर सदा समा सरस्वती भगवती निशेष चार्या Thank you.
Thank you, Dr. Sneha, for your sweet rendition. May I request you all to put your mobile phones on silent mode. At the outset, I invite our Dean, Dr. Praveen Rathi Sir, for his valuable message and blessing for the success of this CM. Sir is also the professor and head of gastroenterology department since 2006. He has also done YouTube किसने ऑन किया? Just skip it. Switch it off. Okay. I invite our Dean, Dr. Praveen Rathi Sir, for his valuable message and blessing for the success of this CME. Sir is also the professor and head of gastroenterology department since 2006. He has done his MD medicine and DM gastroenterology from Mumbai University. Apart from being a good administrator, Sir is a renowned clinician and an avid academician. Sir has contributed in multiple chapters in medical textbooks and has many publications and national and international awards in his credit. It's my honor to welcome Dean Sir with a floral bouquet. I request Dr. Hannah to give a floral bouquet to Dean Sir. I also request Sir to deliver your inaugural speech. Thank you, sir.
A very good morning to all of you. I remember in 1980, I was one of you students sitting in a classroom. Those days, I used to feel we used to start class at 8:30, and morning 8:30 to come into the class and listen to anatomical classes. Lectures, particularly embryology, cellular, was very difficult. But anyway, with time, I have developed. Then I started liking the subject, and then subsequently also, I really like this. So today is a conference on embryology. Wish Shamkishore success for this conference. I'm sure all of you will go back with some message, and you'll learn a lot in this conference. Sir is an excellent team leader, is the captain. Dr. Seema Kambata, she is associated with us as an administrator. She's also in the Nair Golden Jubilee Research, and also looks after MEDC. Dr. Sonone, he is in addition a degree in law. So the department is very active, what I mean to say. Dr. Yuvraj Bhosle, all of you know him. He is in spirituality also. And Nagaraj doesn't need any intro, he is my neighbor, I know him. So, and Dr. Mishra, he is in genetics, and I think this will be his topic of interest too. So with those few words, I would like to take leave because I've got some meeting with them. And once again, I wish you all a very successful this conference. And all of you will go back with some take-home messages. And this conference will be very fruitful, I think. Thank you.
Thank you. Thank you, sir, for your valuable time, your encouraging words, and best wishes. May I request all the participants to please fill the pretest form, which you have already received in the link provided. It's a prerequisite for receiving the attendance of conference for MMC credit points. Also, please mention your name and MMC registration number in the YouTube link, which is provided. I now invite Dr. Yuvraj Bhosle, sir, additional professor in the Department of Anatomy, to explain the logo of the CA. So, respected teachers, faculty from the other colleges, and the students, I'm here to just talk about the hourglass logo of embryology, which you can see here. So in the lower part of the hourglass, we can see the eggs and embryos of different species. And on the top, we see the fetus well developed, and as well as the newborn of different species. But now in between here, in the middle, what we see is the pharyngular stage, the stage where the gills are developed, the pharyngeal arches are developed. That is a stage where at the pharyngular stage, all the species, they look same. Today, you know, we are talking about racism and how people are different and casteism and all. But we need to understand that not only all humans, but all the species that exist, the vertebrates, they all pass through this phase and they look exactly similar to each other. Before we open up the conference, I would like to say that conference में बोल हमारे हैं, the famous 3 idiot dialogues, लेकिन जो शब्द है उनके. So as he said, it was the dream of Dr. Manu Kothari sir, who was teacher of Dr. Shyam Kishore and teacher of all of us.
and that is one reason we are, dedicating the conference to late teacher Dr. Manu Kothari. But to correct Dr. Chatur Ramalingam's speech, which was never corrected after 3 idiots, I would say कि आज TNMC का anatomy department अगर आसमान की बुलंदियों पे है तो उसका श्रेय एक ही आदमी को जाता है. Because विद्या का धन, नॉलेज सबके पास होता है लेकिन बांटता कोई नहीं. तो वैसे सर के पास ये नॉलेज का धन है. एंड यू विल सी इन द webinar that sir will be sitting here only, but what he has taught us and trained us will be presenting here, and none of us are going to behave like Chatur. You will see chamatkar after chamatkar happening here. Thank you so much.
Thank you, sir. Now, I invite our first speaker, Dr. Seema Khambata, madam, who is additional professor in the Department of Anatomy, to give a brief introduction about the basic term and embryological process to start this journey of demystifying embryology.
A very good morning, my colleagues, respected Shyam Kishore sir, who is our guiding force behind this CME, my dear students. It's a great honor and pleasure to introduce this topic of demystifying embryology, and I thank you, sir, for giving me this opportunity. The journey of an embryo starts with a single diploid cell, which multiplies trillion-fold to reach and become a complex human being. Different types of cells and tissues are formed with a wide variety of functions. How the cells get organized into these tissues and organs is the theme of this CM. Let us talk about some basic processes. There is a process of growth, there is migration, there is determination, differentiation, morphogenesis. All of these together form organization, or the integration of these processes is called organization. It is caused by organizers, which are secreted by the embryo itself in a precise and particular sequence. Deviation or any pathological process which is not normal, it will cause congenital abnormalities and teratogenesis. What is growth? Growth means creation of more of an element which is already present. There are 3 types of growth. Multiplicative, which means there is increase in the number of cells by mitosis. This is also called hyperplasia. The second type of growth is auxetic. You can see there is an increase in the size of cells. This is also called hypertrophy. The third is accretionary. Accretionary means there is increase in the intercellular substance. And then fourth is a combined of all this. But basically there are these 3 types: multiplicative, auxetic, and accretionary. What is migration? Cell migration is the directed. Can we just move this? It's the directed movement of a single cell or a group of cells in response to chemical and or mechanical signals. How do you go about this? It's not moving. Extensive cell migrations occur throughout embryogenesis. We have seen in the primitive streak cell migration, then there are neural crest cell migrations. What is determination? Fixation of the fate of different cells of an embryo at a definite time in their development is called determination. What does that mean? It means that up to 8 cell stage, the cells are totipotent. What do you mean by totipotent? That they are capable of giving rise to every type of cell in an organism. After that, comes a stage called impaction. After impaction, they become pluripotent. And by what do you mean by pluripotent? They are capable of giving rise to many, but not all cell types. So basically, the embryo gets divided, the cells of the embryo get divided into embryoblast and trophoblast. So the cells which are in the trophoblast category can form any cells in the trophoblast, and the cells which are in embryoblast can form any cell in the embryoblast. After gastrulation, the pluripotent cells become multipotent. That means they are capable of giving rise to specific subsets of cell type. What do you mean by that? Now we have endoderm, ectoderm, mesoderm. वो नहीं जा रहा, इधर आ, इधर. Can you move this? So the ectoderm, endoderm, and mesoderm, then they give rise to unipotent cells. And by unipotent, we mean that the cells which are performing only one type of function, or there is only one type of cell which is there. Differentiation. Differentiation is different from determination. Here, the young immature cells, they take on special characteristics and they reach their mature form and function. And there are 3 steps which are involved. First is chemodifferentiation, second is histodifferentiation, and third is functional differentiation. What is chemodifferentiation? This is where there is no structural change, but the fate and function is determined by secretion of certain chemicals. It precedes before any changes occur in the cell, but there are definitely some secretion of certain chemicals which happens in the chemodifferentiation state. This can be demonstrated by histochemical techniques. Second is histodifferentiation, where the cells undergo histological changes and those changes are identifiable under a microscope. So we have a neuron, an enterocyte, a hepatocyte, a cardiac cell, an osteocyte. So these different types of cells can be seen under microscope. Third, which is functional differentiation, where now these tissues get organized into organs which assume their function and their functional maturity and their adult appearance. So this is how the neuron will get organized into the brain and spinal cord, then the intestines from enterocytes, liver from hepatocytes, and so on and so forth. It sounds a little confusing, determination and differentiation. So what is the difference between the two? Let me clarify it at this stage. Determination is assignment of the fate of cells, and differentiation means morphological modification of the cells to perform the assigned function. To give you an example or to make you understand it better, when the students are up to 7th or 8th standard, before you take up your stream, whether you want to go into science, commerce, or art stream, those are undifferentiated stage, so that the cells are undifferentiated and undetermined. Then determination happens where you want to become either an engineer or a doctor. So if you take a science stream, you will go into that, or you may take a commerce stream, or you may take a art stream. When you get admission in the medical college, that means the fate is determined that you will now become a doctor. So that is determination. But when you go through the actual process of becoming a doctor of 4.5 years of your study and the internship, that's when your differentiation into a doctor happens. So that is the difference between determination, the fate being determined of the cell. It is assigned, this is what will happen to the cell. And then when the cell undergoes those changes, that is the process of differentiation. Now, the determination and differentiation are brought about by chemicals, which are called organizers. The primary organizer region, we know it is in the region of primitive streak, where the blastopore cells, they have the ability where they can determine the fates of neighboring cells. It secretes a primary organizer, which is a chemical substance. And this is like a simple sterol-like chemical, which is catalytic in nature. And the formative influence, which is exerted by the blastopore cells on its neighboring cells, is called induction. So the process is induction. Just secretion of the cells is not, secretion of the chemical substance is not enough. If I am giving a lecture here and if you are not receptive, I cannot induce you. So the cells where the neighboring cells have to be receptive enough to undergo those changes. So that is called competence. Before that, a primary organizer will act on the undifferentiated cell, which will release the secondary organizer, which will cause the differentiation of cell, which will release tertiary organizers. And this type of differentiation is known as dependent differentiation. And this controls the early histogenesis and organogenesis. As I said, the ability of the cells to react to influence of organizers is called competence or reactive potency. So a competent cell under induction will become determined, and from determination, it will go into differentiation. The inductive effect of organizers is done by two processes. One is evocation and the other is individuation. What is evocation? It is similar to the histological differentiation, which I said, where histological changes will take place in the particular tissue. So for example, nervous tissue is formed, and individuation, where the nervous tissue will get organized into, say, spinal cord in a particular region, medulla in a particular region, brain in a particular region. So that is known as individuation, which is a functional differentiation. Now there's a term called dedifferentiation or redifferentiation. What is dedifferentiation? The cells, when they revert back to less differentiated stage from within its own lineage, and this happens mainly during repair, regeneration, or even in tumor formation. So this is the process of differentiation which is happening. The progenitor cells are differentiating and they form the differentiated cells. These differentiated cells, when they revert back to the progenitor cell, then this is known as dedifferentiation. There are two theories which are suggested for this. One is that the cells can differentiate or redifferentiate depending on the environment. If the environment says that the cells should go back, so if there is an injury or a repair which is needed, then they will go back to that. The other theory states that the certain non-differentiated cells, they exist in the tissue, and when the time comes, then these are the non-differentiated cells which actually start the differentiation and proliferation, which will take part in the repair and regeneration. So these are the two theories which are propagated. Let me give you some examples. Dedifferentiation for repair. Here the axonal injury has taken place. The Schwann cells which were differentiated and which were not proliferating, they had reached that stage of non-proliferation. Now they get dedifferentiated and they start their proliferation. And when they proliferate, they will release certain neurotropic factors which will stimulate the axonal regeneration. So then the regeneration of axon happens. So this is one example of dedifferentiation. As I told you, dedifferentiation, and there is another term called redifferentiation. So what is redifferentiation? Redifferentiation is also called reprogramming, where the differentiated cells, they revert back to pluripotency. So these differentiated cells become pluripotent again. And from pluripotent, they now become in another cell type. They start another function, not the original function, but another function. Example is, in certain cases of bronchogenic carcinoma, they present with secretion of pituitary hormones. So they are not primarily having a pituitary tumor, which is causing the secretion of these hormones, but it is the bronchogenic neoplastic cells which are secreting a pituitary hormone. So this is explained by this process of redifferentiation, where the neoplastic cells from the bronchogenic carcinoma have undergone redifferentiation or reprogramming, and they are now secreting the pituitary hormones. Then there is another term called transdifferentiation or metaplasia. In this, transformation of one cell type occurs into another, and this crosses the barriers between the cell lineages. I have two examples for you here. First one, this is a normal stratified squamous epithelium. This epithelium is undergoing change, which is transdifferentiation. So this one cell that you see is undergoing transdifferentiation, and it is now becoming columnar. This type of metaplasia is seen in Barrett's esophagus, where the esophageal lining normally of esophagus is stratified squamous non-keratinized epithelium. Those cells at that point, it becomes columnar, simple columnar epithelium. So this is known as metaplasia. Another example is where the pseudostratified ciliated columnar epithelium, which is lining the respiratory tract, this one cell, here you can see this blue cell, this undergoes metaplasia or transdifferentiation, and this starts making stratified squamous keratinized epithelium. This happens in smokers. So smoke-induced squamous metaplasia. Let me tell you, these metaplastic changes are precursors of neoplasia. They are not neoplasia themselves, but they are precursors. That means if this continues, then this will lead to cancer. Let's come to dysmorphology. Dysmorphology is study of severe abnormality of body development. Now, this can be caused by influences which operate at an early stage of fetal growth. If there is monstrous maldevelopment, then it is known as teratogenesis. This can be either a single defect or multiple defect. Single abnormality. Let us see what are the different types of single defects. Now, the single defects may or may not have a genetic basis. There are four mechanisms which produce the single type of defect. They are malformation, disruption, deformation, and dysplasia. What is the difference between these four? Let us see. This is a normal development. When there is an intrinsic factor present or congenital abnormality or a genetic basis present, this inherent abnormality causes a primary structural defect of an organ or part, and so that the development of a particular tissue or organ is either arrested or it is misdirected. Example is congenital heart defects, cleft lip and cleft palate, neural tube defects. This is having a genetic basis. So there is an intrinsic factor which is causing this. When there is no intrinsic factor and there is an extrinsic factor which brings about a malformation or a disturbed growth, then that is known as disruption. So abnormal structure of an organ or tissue due to an external factor which disturbs the normal development. These factors can be either ischemia, infection, or trauma. So the fetus himself or herself does not have any abnormality, but the environment in which it is, so either a maternal infection or ischemia or trauma, any of this can cause a disruption. Example is amniotic bands around the limbs. Now, these amniotic bands around the limbs, they can lead to limb defects. By definition, we say it is non-genetic, but sometimes genetic factors predisposed to a certain external factor happening, and that external factor brings about the disruption. Example is in Marfan syndrome. The Marfan syndrome does not cause limb defects per se, but Marfan syndrome causes the amniotic strands to form. So those amniotic strands, because they are formed due to Marfan syndrome, they can strap the limb and they can arrest the limb and can cause the limb defects, right? So it is not happening due to Marfan syndrome, but it is happening due to the external factor, and that is why it is named disruption. Third is deformation. In deformation, you can see there is an external force. This is the external force. In disruption, there was no external force. There was only external factor which was present. Here there is external force. And when there is an external force, it is abnormal mechanical force. And this causes distortion of an otherwise normal structure. So there can be dislocation of the hip. There can be mild positional talipes equinovarus, which is also known as a club foot. And this is seen in oligohydramnios, which is less amount of amniotic fluid, or overcrowding due to twinning or abnormal uterus. This occurs late in pregnancy and it has a good prognosis with treatment. Dysplasia. What is dysplasia? Where the organization of the tissue is only abnormal. So that within a particular tissue or organ, there are abnormal cells present. Let me give you an example. Now, this type of abnormal cells will be present in the tissues, wherever that particular tissue is present throughout the body, there those abnormal cells will be present. Example is achondroplasia, which is the dwarfism that you see. That is due to abnormal cartilage, which affects the fetal development. Now, those cartilage tissues all over the body will be affected, and that will lead to the short stature and arresting of growth. So that is known as dysplasia. The second is hypohidrotic ectodermal dysplasia. Now, ectodermal dysplasia means here all the derivatives of ectoderm will be affected. And when I say derivatives of ectoderm, that means hair, nails, skin, sweat glands, teeth, even ear, even eye, or whatever is developing from the ectoderm, it will be affected. And these are mostly caused by single gene defects. There is a high risk that it can be inherited in siblings and offsprings because there is a genetic basis. We come to multiple abnormalities. Multiple abnormalities can be either sequence, they can be syndrome, or they can be association. What is the difference between all of them? Sequence is when there is a consequence of a cascade of events which is initiated by a single factor. There is one factor which initiates so many things and then causes a lot of things to happen. So example is Potter sequence. In Potter sequence, there is a basic one primary factor, which is either there is a chronic leakage of the amniotic fluid or there is a defective urinary output. Either of these will cause oligohydramnios. And this oligohydramnios will bring about fetal compression. And this fetal compression will cause squashed facial features. It can cause hip dislocation. It will cause club foot. It will cause pulmonary hypoplasia. And pulmonary hypoplasia can even cause early neonatal death. This sounds something similar, right? We have done it in deformation. So when only one single defect is present, then it is called deformation. But if all of these are present together, then that is called sequence. Get the difference between the sequence and deformation, right? Syndrome. What is a syndrome? So when there is a set of consistent and recognizable pattern of abnormalities seen in an individual or more than one individual, and there is a known underlying cause. And this known underlying cause can be chromosomal abnormality or it can be a single gene defect. So chromosomal abnormality example is Down syndrome. Single gene defect example could be cystic fibrosis. There are several other examples. But when the cause is known and you see a certain defined set of abnormalities in individuals who are affected by that particular cause, that will be called syndrome. If a similar set of abnormalities occurs, but there is no cause which is known, then it is called only association. So certain malformations which tend to occur together more often than by chance, where the cause is unknown, then it is termed association. And these, how are they called? They are called as acronyms, or they're named as acronyms. Acronym means VATR. VATR means but there will be vertebral anomaly, anal anomaly, tracheoesophageal anomaly, and renal anomaly. There could be, this is vectoral, which means vertebral again, cardiac, tracheoesophageal, renal, anal, limb. All these anomalies are named after the association is named after the anomalies which are caused. Example where association can be called syndrome. So charge was initially called an association because charge means coloboma of the eye. There is an eye defect, heart, atresia of nasal choanae, retardation of growth, genitourinary system is affected, and ear abnormalities. All these abnormalities, initially the cause was not known, so it was called charge association. Now we know the cause, and that is CHD7 mutation, and that is why it becomes a charge syndrome. So the only difference between association and syndrome is cause being known or unknown. Then let me come to theories of preformation and epigenesis. What is preformation? Preformation states that the germ cells of each organism contains preformed miniature adults, and that will unfold during the development. So the program is already there, and come what may, this is what the individual will be. The other theory states epigenesis. Epigenesis means there is no program. As and how the individual is subjected to the different environments, that will shape up the individual. So it is unformed, the material is unformed, and with time, as it emerges, it will keep on forming the individual. What is the accepted theory? Accepted theory is a combination of two. And what does that say? It says that every individual has a preformed genetic blueprint. And this genetic blueprint, by epigenetic processes, reaches the final stage. And it also means that the epigenesis can control. There are certain genes which are present, but those genes can be switched on or off by epigenetic. So it's not just because the presence of the gene is there, so this will happen, but those genes can be switched on and off by epigenetic processes, and that will form the final individual. So that is the accepted theory of preformation and epigenesis. If it were pure epigenesis, then every individual would be alike. Now let's discuss that upper limb prototype as a developmental model. There are 4 stages involved: initiation, specification, growth, and differentiation. Initiation happens on day 26 for upper limb and on day 28 for lower limb. This is a transverse section of the embryo which is seen. This is somatic mesoderm. This is the lateral plate mesoderm. And here is the limb bud. This is the ectoderm which is lying here. So how does it start? It starts with the proliferation of the somatic mesoderm and the lateral plate mesoderm. Both go towards the side into the overlying ectoderm. And the factor which is responsible for that is known as the fibroblast growth factor. Once this happens, this is in here, the mesoderm is the prime mover. And why do we say mesoderm is the prime mover? Because if you remove the mesoderm, or if there is no growth of the mesoderm, there will be no limbs. Or if the mesoderm is transplanted into another area, then there will be ectopic limbs. So that's why we know that mesoderm is the prime mover. Specification means whether upper limb will develop or lower limb will develop. And that specification is decided by the fibroblast growth factor number 8, which is controlled by Hox genes. Stage next is the growth stage. In the growth stage, the original overlying ectoderm. This is the overlying ectoderm. This becomes the apical ectodermal ridge. This starts growing distally in this direction, and this establishes this proximo-distal axis. As the bud grows, there is this progress zone which is formed here, which will cause the growth. And why it will cause the growth? Because there is undifferentiated divided mesenchyme present here. Then there is another zone of polarizing activity, which is this purple zone here, which is formed. This zone of polarizing activity, it develops on the posterior margin of the developing bud. And this will decide the posterior-anterior axis or anterior-posterior axis. This axis is decided by this zone. Now, what does this zone do? The development of this zone is mediated by the sonic hedgehog genes. It releases retinoic acid. Now, this retinoic acid, you can see here, there is a higher concentration here and there is a lower concentration here. So there is a concentration gradient of retinoic acid. This concentration gradient decides what type of digit will be formed. So if there is a high concentration gradient, little finger will be formed. If there is low concentration gradient, thumb will be formed. How did we come to know about it? The zone of polarizing activity here was transplanted on the anterior side. As this was transplanted, it started producing the retinoic acid, and now the retinoic acid gradient became high over there. So it resulted in two fingers. You can see here, two fingers. So there are two little fingers. One is on this side and on this side. And in the center, where there is less retinoic acid concentration, there the thumb is there, right? So this explains that. Last process is differentiation. What is differentiation? The upper limb has three parts: stylopod, zygopod, and autopod. As the cells leave the progressive zone, they differentiate into the appropriate mesenchymal structures like the skeleton, connective tissue, vessels, etc. of the arm, forearm, and hand. The stylopod will form the arm, the zygopod will form the forearm, and the autopod will form the hand. One example of thalidomide disaster. In thalidomide disaster, the
I hope the online participants are able to see. Uh, Thanks to Dr. Seema Madam for such a wonderful session. It's a request to all the delegates. It's a request to all the delegates who are on the WhatsApp group. If you have any questions, then please write in that WhatsApp group only, so that at the end of all 5 sessions, we will answer it together and it will be a question answer session. So it's my great pleasure to now invite our next speaker, Dr. Dattatreya Dombe sir, Associate Professor in the Department of Anatomy. He will speak on cell proliferation, excavation, and imagination.
Good morning to all students, my seniors, my colleagues. Into this CME of demystifying embryology, I am going to talk regarding the morphogenesis of embryo by 3 processes: cell proliferation, excavation, invagination with surface detachment. First process in morphogenesis is cell proliferation. We know that our embryo, we all are developed from a single cell called as zygote. Zygote proliferate to give rise to billions and trillions of cells. So whatever these cells which are proliferated, these are present in different forms and shapes. Like cells are present after proliferation, they are present in the form of clusters, cords, blocks, spheres, sheets. Cluster of cells. Cell proliferate and there is a aggregation of cells. They are present in the form of a rounded cluster. The examples where we get the cluster of cells, we get cluster of cells in morula, anterior pituitary, parafollicular cells, parathyroid gland, islets of Langerhans, zona glomerulosa, interstitial cells of Leydig in testes, metanephric blastema, in the development of tongue, lymphatic follicles, white pulp of the spleen. These are the areas where we get the cluster of cells. We know this structure. The simple single zygote cell will divide to form the 2 cells. Then we get the 3 cell, 4 cell, 16 cell stage, 32 cell stage. So whatever these cells proliferate, they group together and there is a formation, presence of a bunch of cells called as a cluster of cells. Each dividing cell over here is called as a blastomere. If there is an early separation of these blastomeric cells, then there is a formation of a dichorial placenta and there are different grades of multiple pregnancies. We get cluster of cells in the anterior pituitary. The anterior pituitary is developed from the roof of oral cavity into the embryo, which is called as a stomatodeum. Some cells from the roof of stomatodeum, they grow upwards, which is called as the Rathke's pouch. So these cells from the Rathke's pouch, which are ectodermal in origin, they further proliferate and there is a formation of a cluster of cells. So in the anterior pituitary, we get like this cluster of cells, which are then differentiated into the chromophobic cells, chromophilic cells, some are acidophilic cells, and some are basophilic cells. Also, we get cluster of cells in the islets of Langerhans, endocrine part of the pancreas. We know pancreas is developing from the dorsal pancreatic bud and ventral pancreatic bud. Each bud will have the ducts. We'll have the duct of dorsal pancreatic duct and the duct of ventral pancreatic duct. This terminal part of the duct will, there is a budding of the terminal part of the duct, and this budded of part of these ducts will give rise to the cluster of cells, which are called as the islets of Langerhans. Also, we get such type of cluster of cells by mesenchymal cells migrating into the cortex of suprarenal gland. Here we get the cluster of cells. Cluster of cells, again, we get in between the seminiferous tubules. These are the seminiferous tubules. In between the seminiferous tubules, some mesenchymal cells will be there. They will proliferate and give rise to the cluster of cells, which are here called as the interstitial cells of a lady. Another area where we get the cluster of cells in the development of a kidney. We know kidneys are developing from pronephros, mesonephros, and the metanephros. Particularly into the metanephric part, we are getting the cluster of cells, which are called as a metanephric blastema. Then into this cluster of cells, there is a formation of a vesicle in the center that is called as a metanephric vesicle. Here we have the cluster of cells, which is called as a metanephric blastema. Near to this cluster of cells, metanephric blastema, at one end we have the mesonephric duct, and at another pole we have the developing aorta. So from this cluster of cells, which are called as metanephric blastema, there is a formation of a vesicle called as a metanephric vesicle. Then one end of this metanephric vesicle is attached to the mesonephric duct. Its another end is attached to the vessel coming from the aorta, and in this way there is a formation of the nephron and different part of excretory part of the kidney. Again, we get such cluster of cells in the development of tongue. Under the endoderm of a first pharyngeal pouch, the mesenchymal cells will proliferate, and there is a formation of the swellings, which are called as a lingual swellings. So we have here the two lingual cells and the tuberculum impar, where the mesenchymal cells, they are arranged in the form of a cluster. After having the cluster shape of arrangement, there is another shape by which cell proliferate and arrange, that is the cords of cells. Cords of cells means proliferated cells, they are arranged in the linear manner. We get cords of cells in the thyroid gland, in the development of a nasolacrimal duct. These cords of cells are present in the different development of salivary glands. All the salivary glands, they are developed in the form of cords of cells, parotid, submandibular, sublingual. Cords of cells also we get in the development of esophagus and the duodenum. In the development of liver also we get the cords of cells called as the hepatic cords. These cords of cells also present in the cortex of suprarenal gland, particularly zona fasciculata and zona reticularis, where we get the cords of cells. We get cords of cells in the developing gonads called as the sex cords. Also we have nephrogenic cords. So here we can see the development of the thyroid gland from the foramina cecum. At the area of the foramina cecum, some of the endodermal cells grow downwards, and they are present in the form of a cord. This is the cord of cells. Later on, this cord of cells there is a canalization into these cords of cell, and there is a formation of a thyroglossal duct and further development of thyroid gland. Also, we are getting the cords of cells in the development of a nasolacrimal duct. Here we have the frontonasal process. This is the medial nasal process. This is the lateral nasal process. This is a maxillary process, and here we have the developing eye. So in the lateral nasal process and maxillary process, here we get one furrow that is called as a naso-optic furrow. In the naso-optic furrow, some ectodermal cells are formed. They are present in the form of a cord, and they are buried under this naso-optic groove, which later on will give rise to the nasolacrimal duct. The cords of cells are also present in the development of a salivary gland like parotid, submandibular, and sublingual gland. Here, these parotid glands are developed into the angle of a stomatodium. We have the maxillary process, we have the mandibular process. In between this, into this angle, the cords of ectodermal cells will go, and there is a formation of a bud. This bud will go into the underlying mesoderm, and this bud will give rise to the cords. So like this, there is a cord of cell, and underlying there is a mesenchymal cells. Then there is a further development of further stages of development of parotid gland by the further canalization into these solid cords. These cords of cells are present into the development of esophagus and duodenum. This esophagus and duodenum is early present in the form of a cord. Later on, there is a canalization into this solid cord, and with this canalization, we are getting the lumen formation into the esophagus and duodenum. If there is some problem in the canalization, there is the atresia, esophageal and duodenal atresia, if the solid cords are not canalized. We get cords of cells in the development of the liver. We know that liver is developed from the hepatic diverticulum. This hepatic diverticulum is coming in contact or in relation with the septum transversum. Some of the endodermal cells from the hepatic diverticulum goes in the manner of a cords in the septum transversum, and these cords are called as the hepatic cords. The hepatic cords, they present in the form of an anastomosing network, and in this way there is a formation of a liver. These cords of cells also we get into the development of suprarenal gland. Cortex of the suprarenal gland. In the upper part of the cortex, zona glomerulosa, the cells are present in the form of a cluster, but in the fasciculata, and reticularis, we get the arrangement in the form of cords. In the zona reticularis, these cords, they crisscross each other. Next area where we get the cords of cells is in the developing gonads. Here we have the genital ridge. This genital ridge is covered by coelomic epithelium. This coelomic epithelium, the cells from the coelomic epithelium proliferate and give rise to the cords. There is a formation of cords into this genital ridge from this coelomic epithelium, and whatever these cords are formed at around the 6th week, this is called as the bipotential stage of the gonad or indifferent stage of the gonad, where we get the cords. These cords are called as the primary cord. At this stage, the sex of the embryo is not determined. In the 7th week, whatever these primary cords are there, these primary cords will have the two areas, the cortex and medulla. In case of a male, the cortical cords will degenerate, and these are replaced by the tunica albuginea, whereas medullary cords will sustain and they will form the seminiferous cords, which later on will form the seminiferous tubules. These cords are called as secondary cords. Similarly, in case of a female, the cortical cords will sustain, where inside it there will be the primordial germ cells, and later on which will be forming the primordial follicles. In case of the female, the central medullary cords which will be degenerating, and these are called as the Fluger's tubules. So this is the formation of our primary cords and secondary sex cords in case of developing gonads. Again, we get the cords, the pattern of cords into the development of kidney, nephrogenic cords. These nephrogenic cords are present in the intermediate mesoderm. These nephrogenic cords are present only in a mesonephros. We know the kidneys are developing from the pronephros, mesonephros, and metanephros. Pronephros in case of human being is totally degenerating. Mesonephros is forming the mesonephric tubules, and into that area only we are getting the cords which are called as the nephrogenic cords, which in case of a male is forming the superior aberrant tubules, inferior aberrant tubules, efferent ductules, vasa efferentia, seminiferous tubules, ejaculatory duct. Male genital ducts are formed by these nephrogenic cords. In case of a female, there is a regression, and only remnants will be present in the form of epiphoron and periphoron, Gartner's ducts. There are certain areas where we get the cluster of cells and cords of cell. For example, in case of a spleen, we get the white pulp where we get the cluster of cells, and in a red pulp where we have the splenic cords, the cells are arranged in a linear manner. Similarly, in case of a lymph node, also in the white into the lymphatic follicles, we get the aggregation of cells in the form of a cluster, and there we have the medullary cords where the cells are arranged in a linear manner. One more example already I told you where we get the clusters and cords. Zona, cortex of the kidney, cortex of suprarenal gland, where in a zona glomerulosa we get the clusters, and zona fasciculata and reticularis where we get the cord-like arrangement. After the cords, then next arrangement of the cell proliferation is sheets of cells. We get sheets of cell in the epidermis. We get sheets in the smooth muscles. We get sheets in the form of a wall of GI tract, wall of urogenital tract, and wall of respiratory tract. In case of epidermis, we are getting a sheet. How the epidermis is developed? Initially, entire embryo is covered by a single layer of cuboidal cells that is called as a surface ectoderm. Then this surface ectoderm will give rise to the another cells, and there is the formation of the two layers. One upper layer, which is called as the periderm, and the layer below it is the basal layer, which is the germ layer or germinative layer. So this basal layer, again, as the embryo grow, this basal layer cells proliferate, and they will form one more layer superficial to it. So in this way, there is a formation of sheets of three layers. One is a upper one, which is called as the periderm, then basal layer. Three layers will be formed. These three layers are named as periderm, intermediate layer, and basal layer. Again, as the embryo develops, if there is a formation of thin skin, we'll get the 4 layers. If it is a thick skin, we'll get the 5 layers. Like the basal layer will be the stratum. Basal layer is germinative layer, that is called as stratum basale, stratum spinosum, stratum granulosum, stratum lucidum, and stratum corneum. In this way, we'll get the different layers one upon another. And into this epidermis also there is a migration of some melanocytes, and these melanocytes, they are neuroectodermal in origin. So here in the skin above is epidermis, below it we have the dermis. This dermis is present in the form of a dermal papilla. Whatever these dermal papilla are there, they will anchor the epidermis on it. So this dermal papilla will prevent the easy stripping of the epidermis. So that is the function of dermal papilla dermis. Then next is a arrangement of cells in the form of blocks or segments, which are called as the somites. Somites is a very good example where the cells are arranged in the cubical masses. After cell proliferation, next method of morphogenesis is excavation or hollowing out. During the morphogenesis, there are certain areas where the cavities are formed. We get cavities in the developing follicle. Cavities are seen in the morula, which is called as a blastocystic cavity. Cavities are seen in the extraembryonic mesoderm. Cavities are there in the intraembryonic mesoderm. Also, we get cavities into the blood islands during the process of vasculogenesis, formation of the vessels. So here we can see the formation of cavities in the developing follicles, ovarian follicles. So these are the cavities. like this cavities we see. For the formation of a cavity in case of follicle, the reason is a follicle stimulation, FSH, follicle stimulating hormone. This follicle stimulating hormone will have affect more, it will cause more effect onto the follicles as compared to the growth of the follicles. The other cells, they will grow comparatively in a low way. That is why the cavities are formed into the follicles. Again, we get cavities into the morula. The cavities in the morula is called as a blastocystic cavity. The reason for formation of a cavity into the morula are whatever the cells which are formed from the parent cell. From the mother cell, we are getting the two daughter cells. Whatever the two daughter cells are from newly formed daughter cells will have the less volume than the parent cell or mother cell. Because during the cell division, some of the cytoplasm is used by this cell division. That is the reason cavity is formed into the morula. That cavity is called as a blastocystic cavity. Other areas where we get the cavity is in an extraembryonic mesoderm. Cavity is formed. That cavity is called as a extraembryonic coelom. We get cavities into the similar cavities we get into the intraembryonic mesoderm. This is called as a intraembryonic coelom, which later on is forming the peritoneal, pleural, and pericardial cavity. Also, we get cavities into the cluster of cells which are forming the hemocytoblast. From this cluster of cells, certain areas we also get the cords of cell. Cavities will be present into this cluster. Some of the cells from the cluster will form the endothelium. Some cells will form the other cells of the blood, like red blood cells, white blood cells. So into this cluster, cavities form and vessels are formed. So these are the blood islands. Into these blood islands, cavities are formed, and which are leading to formation of the vessels. Third method of morphogenesis is by invagination and surface detachment. Invagination with surface detachment. There are two ways of invagination. One is a linear invagination and another is a spherical invagination. Examples of a linear invagination is a formation of a notochord, formation of a neural tube. In surface spherical invagination with surface detachment is in a lens placode, otic placodes, Rathke's pores, dental vesicle, and the dental lamina. Linear invagination with surface detachment in the formation of a notochord. We have seen that notochord is formed at the cranial part of primitive streak. Primitive streak here is acting as a primary organizer. At its cranial end, there is a primitive knot is there. From this primitive knot, there is a formation of a pore. This called as a blastopore. Some cells proliferate from this blastopore, goes towards procaudal plate. There is a formation of a notochord that is called as a primitive notochord. Again, there is a canalization into this primitive notochord, and that is called as a notochordal canal. With this further development, there is a formation of a notochordal plate. There is a one stage where this there is a communication between the amniotic cavity and yolk sac cavity through this canal, which is called as a neuroenteric canal. Again, from this neuroenteric canal, next stage is a notochordal plate. From this notochordal plate, again we are getting the solid notochord, which is called as a definitive notochord, and this definitive notochord will detach from its surface. Sometimes there is a persistence of neuroenteric canal will result in the communication of a small intestine with the lumbar subarachnoid space. If ends are closed and middle part persists, it will become cystic swelling in front of thoracic and lumbar vertebrae. The way by which notochord is formed, somehow in a similar way, there is a formation of a neural tube. For the formation of the neural tube, this notochord is acting as a secondary organizer. during the formation of the neural tube, there is this notochord will affect onto the surface ectoderm, which is converted into the neuroectoderm. There is a formation of the neural folds. There is a neural groove. With this deepening of the neural groove, there is a formation of this neural tube, and this neural tube will detach from the surface. So there is another surface detachment that is called as a spherical invagination with the detachment in the development of a lens. Here we have the ectoderm, we have the optic vesicles. This area is called as the lens placode. Then there is a formation of a lens pit. With this lens pit, there is a formation of the lens vesicle, and this lens vesicle will detach from the surface, and further it will give rise, it will form the lens. The way lens is formed, similarly, the ear will develop. Here we have the otic placodes. These otic placodes are converted into a pit called as the otic pid. This otic pid will again detach from the surface, and there is a formation of an otic vesicle. Similarly, in the development of an anterior pituitary, we have seen that anterior pituitary is developed from the roof of stomatodium. There is a Rathkesh pouch. This Rathkesh pouch will come in contact with the down growth from the diencephalon, and this pouch, Rathkesh pouch, will again detach from the underlying surface, and which will give rise to the anterior pituitary. If there is a persistence of some part or remnants of a Rathkesh pouch, which will give rise to the craniopharyngioma, then this is the last example of a spherical invagination with the surface detachment in the development of a tooth. Here we have the oral mucosa. From the oral mucosa, some ectodermal epithelium is going underlying mesenchyme. There is a formation of a dental lamina, dental bud, and with this dental lamina, dental bud, there is a formation of development of the tooth in the form of a early Bell stage, late Bell stage. Whatever this dental lamina is there, this part of a dental lamina will disintegrate from the surface, and there is a formation of a tooth. So both deciduous tooth and permanent tooth, they are detached from the surface, and later on this will erupt. So this is how the morphogenesis of embryo is occurring by three processes. One is the cell proliferation, another is excavation, and third method is invagination with surface detachment. Thank you.
Thank you, Dr. Dattatreya, sir. I now call upon stage Dr. Shobha Gaikwad, Madam, Associate Professor in the Department of Anatomy, to talk about the processes of migration, splitting, lamination, separation, inclusion, and embedding.
So thank you, Dr. Shubhangi. So good morning, all my respected teacher, my dear colleagues and students. So I will explain the further process of morphogenesis. These are the migration, splitting, lamination, and separation, inclusion, and embedding. So let us see first about the migration. So the migration is the fundamental process which helps to establish and maintain the proper organization of multicellular organs. It is required in cell locomotion. There are two types of migration. One is single cell and another one is the collective cell. So single cell migration, it occurs when body gives response to the inflammation by migration of leukocytes, while the collective cell migration occurs in morphogenesis, wound healing, and cancer cell invagination to the distant organ, that is the metastasis. So here we can see these are the example. This is a list showing the examples of. So let us see one by one here. So the first example of migration here is the fertilization. So here we can see after ovulation, the ovum is immediately captured by the fimbriated end of fallopian tube. Then it migrates to the ampulla. Then through the uterine cavity, the spermatozoa passes. It passes through the proximal part of fallopian tube, and fertilization occurs in the ampulla. Then after fertilization, this fertilized ovum migrates toward the uterine cavity. While migration, there are the various changes which occurs, and ultimately it forms the blastocyst here. Now, if this blastocyst, migration of this blastocyst occurs towards the distal part of fallopian tube instead of towards the uterine cavity, then it may get implant over the fimbria. If it come outside through the fimbriated end of fallopian tube, then it may get implant towards the over the adjacent organs. Like here we can see it has shown the implantation on the ovary, mesentery, and sometimes even it migrate towards the pouch of Douglas, and the implantation may occur. Then this blastocyst, it may get migrate towards the uterine cavity, and before that it may get implant into the fallopian tube only. Then it causes the this tubal pregnancy. So in this image we can see this is the fetus here. Up to the 2 months of pregnancy, there is no any as such symptom, but as the pregnancy advances, then it may cause the rupture of the fallopian tube and may cause the hemorrhage, and it may create the acute surgical emergency, and it may become life-threatening for the mother. Now, if the blastocyst migrates towards the uterine cavity and implants in the lower uterine segment instead of in the upper uterine segment, then this condition is called as the placenta previa. There are 4 degrees of placenta previa. In the first degree, it forms the placenta at the junction of the upper uterine segment and the lower uterine segment. In second degree, the implantation occurs at the lower uterine segment. In third degree, the placenta is present in the lower uterine segment, but the margin of this encloses the internal os completely. In fourth degree, the placenta is placed completely horizontally in the lower uterine segment, and the internal os, it is completely closed. So the importance of this placenta previa is that it may cause the premature separation of placenta and may cause the severe hemorrhage, and which may be life-threatening for the mother also. Now let us see the further examples of migration. When there is a formation of bilaminar jump disc, then also the migration occurs. So here we can see this is the inner cell mass. On the outer side here we can appreciate here this is the outer cell mass. At this stage also it is covered by the zona pellucida. Then the zona pellucida disappears, and the size of the cells, the outer cell size decreases. It becomes smaller in size, while inner cell mass cell also undergoes in compaction. They are compactly arranged. Then there is further change in the inner cell mass, and it is arranged in the form of 2 layers. The upper layer is called as the epiblast, while lower layer is called as the hypoblast. Few cells from the epiblast migrate and encloses the amniotic cavity, while from the hypoblast, the cell migrate and encloses this primary yolk sac here. So these are the changes which occurs in the inner cell mass. Then in the formation of external mesoderm also the migration process is involved. So here we can see this is the bilaminar jump disc, amniotic cavity, the yolk sac, and surrounding to this trophoblast undergoes proliferation and migration, and surrounding these structures from the extraembryonic mesoderm. In the formation of notochord also, the migration is involved here. So here we can see this is the precaudal plate at the cranial end. At the caudal end, we can appreciate here this is the primitive streak. At the tip of the primitive streak, the cells proliferate and from the primitive node, further cell proliferate and reach up to the caudal end of the precaudal plate. Here we can see these are the various stages of the formation of definitive notochord, which we have already seen here. Then in gastrulation also the migration process is involved. So here we can see this is the epiblast. In the median plane, we can appreciate here this is the primitive streak. So cells from the primitive streak proliferate and migrate in between these two layers, that is epiblast and the hypoblast, and form the intraembryonic mesoderm. Simultaneously, few cells proliferate and migrate in a forward direction and replaces the cells of the hypoblast and form the endoderm. And lastly, the cells of the epiblast, these are replaced and form the ectoderm. So ultimately, all the three germ layers are derived from the epiblast only. So here we can see neurulation, which we have already seen. So here we can see this is the notochord. The surface ectoderm modifies and form the neural plate. Then these are various stages showing the development of neural tube. On the dorsolateral aspect of this neural tube, here we can see these are the neural crest cells forming by a migration of it from the neuroectoderm here. Then the neural crest cells migrate to the different parts of the body, and it has an inducing effect to that particular part of the body. So because of neural crest cells, it may induce the formation of the sensory ganglia of the 5th, 7th, 9th, and 10th cranial nerve, then dorsal root ganglia of the spinal cord, then parasympathetic ganglia like otic ganglia, submandibular ganglia. Then it also induces the formation of the meninges of the brain. Then it also migrates toward the skin for the formation of melanocytes. So there are various structures derived from the neural crest cells here. So if it fails to migrate, then it may cause the congenital megacolon, aorticopulmonary septal defect, cleft lip, cleft palate, frontonasal dysplasia, and albinism. Here in this image, we can see before the head folding of the embryo, how the structures are arranged. So here we can see this is the notochord. Just ventral to this, here we can appreciate this is the neural plate. Then cranial to this, here this is the precaudal plate, and more cranial to this is the cardiogenic area. And the highest structure here, this is the area where the septum transversum develops. During the folding, here the septum transversum lies most ventrally. Just behind to this is the developing heart and the pericardium. More posterior to this is the oropharyngeal membrane or the precaudal plate. So during this stage only, this septum transversum, which forms the central tendon of the diaphragm, receives the nerve fibers from the cervical segment of the spinal cord. These are C3, C4, C5. So after complete head folding, here we can see the septum transversum. It is placed below to the developing heart and the pericardium. So once the septum transversum receives the nerve fibers during folding, these are dragged along with till it reaches to its definitive position. That is why the phrenic nerves are placed on either side of the heart. Then in the feds of somites also, the migration process is involved. So here we can see this is the neural tube, and on either side of this, we can appreciate here these are the somites. Somites are again divided into three parts: dermatome, myotome, and sclerotome. Dermatome migrates toward the skin and from the dermis, while sclerotome migrates toward the neural tube and from the vertebral column and the ribs. While this myotome migrates toward the different parts of the body and forms the skeletal muscle of the entire part of the body, including the skeletal muscles of the upper lip and the lower lip. So in a case of development of tongue also, there is some migration. So here we can see these are the four arches here. So here we can see the second pharyngeal arch, it is buried because of the proliferation and migration of the mesenchymal cells from the third pharyngeal arch over the second pharyngeal arch. That is why the posterior one-third part of the tongue, it is supplied by the glossopharyngeal nerve. Then in the development of thyroid gland, also the migration is involved. So here we can see this is a location for the foramen cecum at the junction of the anterior 2/3 and the posterior 1/3 part of the tongue. So this is the area where the thyroglossal duct develops. Then it passes through the substance of the tongue. Then it passes in front and below to the hyoid bone. Then it passes in front of the thyroid cartilage, and then ultimately it reaches to its definitive position, that is opposite to the second to the fifth tracheal rings. So this lower end of thyroglossal duct comes in contact with the ultimobranchial body. That is why the further descent of thyroid gland will not occur. But if it fails to come in contact with the ultimobranchial body, then it may reach to into the mid-asternals. Then it may form the superior mid-asternal thyroid gland. So if the thyroglossal duct fails to migrate along its pathway, and if it arrests on its pathway, then it may cause the formation of the development of the ectopic position of thyroid gland. Now let us see in case of development of thymus and inferior parathyroid gland, how migration is involved. So here we can see this is the third pharyngeal pouch, and this is the fourth pharyngeal pouch here. The third pharyngeal pouch is again divided into two parts. The cranial part forms the parathyroid tree, while the caudal part forms the thymus. The thymus gland of both sides fuse in the median plane and forms the lobes of the thymus, and it lies in the neck region. But its further descent into the superior mediastinum is prevented because it comes in contact with the ultimobranchial body. Then once the thymus is developed, then along with the thymus, the third this parathyroid tree is dragged along with it. That's why this inferior parathyroid tree is located at a lower level than the parathyroid 4. That is why this parathyroid 3 is called as the inferior parathyroid gland, while the parathyroid 4 is called as the superior parathyroid gland here. Then in the descent of testes also the migration is involved. So normally the testes that develop on the posterior abdominal wall here, but for the normal spermatogenesis, it has to reach into the scrotum. So at the 3rd month of intrauterine life, it reaches into the iliac fossa. At the beginning of the 7th month of intrauterine life, it lies in the deep inguinal ring. It passes through the inguinal canal during the 7th month of intrauterine life, and at the end of the 7th month, it reaches up to the superficial inguinal ring. Then at the end of the 8th month of intrauterine life, it reaches to the bottom of the scrotum here. If it fails to descend along its pathway, then it may causes the undescended testes, which is also called as the cryptorchidism. Now, in case of ectopic position of testes, here the testes migrate or passes through the entire length of inguinal canal, that is through the deep inguinal ring, then inguinal canal, it reaches up to the superficial inguinal ring. But after that, it may migrate towards the any part of the this lower abdomen here. So it may migrate towards the it may lie beneath to the skin of the lower part of the abdomen. It may lie beneath to the skin of the femoral region. It may lie above to the dorsal aspect of the penis or into the perineal region. Now let us see how the migration is involved in the ascent of kidney. So as we know, the kidneys are developed from the metanephros. That's why initially it lies in the pelvis. As it lies in the pelvis, these are supplied by the lateral sacral branches of the abdominal aorta. As it ascends in upward direction, it receives the branches from the higher branches from the abdominal aorta, lateral branches from the abdominal aorta. Finally, it reaches to its definitive position, that is opposite to the lumbar vertebra. Then these are supplied by the renal arteries. So the renal arteries, these are considered as the lateral branches of abdominal aorta. So if any vessel comes on its way, when it ascends in upward direction, then the kidney will lie in the pelvic region only. At that time, this pelvic type of kidney, it is supplied by the umbilical vessels. Then in case of kidney, here we can see the lower poles of both kidneys are fusing with each other and forms a horseshoe kidney here. So this type of anomaly causes the ascent of kidney up to the midway here. The further ascent will be prevented because the inferior mesenteric artery comes on its way here. Now let us see how the primordial germ cell, migration of primordial germ cells are involved in the formation or the development of gonads here. From 3rd to 5th week of intrauterine life, the primitive streak has an inducing effect on the epiblast. So to prevent this inducing effect from the primitive streak, a few epiblast cells migrate towards the yolk sac here. Once the inducing effect of primitive streak goes in the 5th week of intrauterine life, then this epiblast cell again migrate towards the developing gonads, and here it forms the primordial germ cells. So if it fails to migrate towards the developing gonads, then further development of gonad will not occur because it has the inducing effect on these developing gonads. Then in case of development of medulla oblongata, also the migration is involved. So here we can see this is the 4th ventricular cavity. This part, this is the roof of the 4th ventricle. On the ventral aspect, we can see here, this is the basal plate here, and dorsolateral to this, here we can appreciate, this is the alar plate. Few cells from the alar plate detaches and migrates on the ventral aspect of this basal plate and forms the olivary nuclei. In case of pons, again, here we can see this is the 4th ventricular cavity. This is the basal plate. Dorsolateral to this, here we can see this is the alar plate. So few cells from the alar plate separates and migrate on the ventral aspect of the basal plate, forms the pontine nuclei. Meanwhile, few cells from the alar plate on the dorsal aspect proliferate and forms two important structures. These are the rhombic leaves. The rhombic leaves of the two sides fuses with each other in the median plane and forms the cerebellum. In case of midbrain, here again we can see here. So alar lamella, few cells from the alar lamella migrates on the ventral lateral aspect of the basal plate and forms the substantia nigra and the red nucleus here. And the basal plate of this midbrain forms the cranial nerve nuclei, the 3rd and the 4th cranial nerve nuclei, and the Edinger-Westphal nucleus. Now let us see the next process of morphogenesis, that is lamination. So lamination is the process in which the cells are arranged in the form of plates and layers. The importance of this is that it helps to organize the sensory input and the motor output. Second, it helps to reduce the length of the neurons, and that's why it reduces the conduction time and increases the speed of response. Also, in a limited space of skull, more number of neurons can be occupied because of this lamination. So these are the few examples of lamination. So these are the development of spinal cord, the brainstem, cranial nerve nuclei arrangement, cerebral cortex, cerebellar cortex, hippocampus, superior colliculus, and retina. Out of this, let us see in more detail about the lamination of spinal cord. So here we can see this is the neural tube. The lateral part, it is more wider than the roof and the base here. Then these are the ependymal cells. Ependymal cells proliferate and forms the mantle layer. Cells in the mantle layer proliferates and migrate on the outer side from the marginal layer. Here we can see this is the marginal layer. Meanwhile, in the neural tube, one sulcus appears at the middle point here. So the area ventral to this forms the basal plate, while dorsal to this forms, here we can see the dorsal to this here, it forms the alar plate here. Then there are few changes occurs in the neural tube here. The dorsal part of this neural tube fuses in the median plane and forms the posterior median septum here. And the remaining part of this neural tube forms the central canal. There are some changes in the mantle layer also. The mantle layer of the basal plate proliferates more rapidly than this dorsal alar plate here. And that is why here the basal plate form the anterior gray column, and because of the rapid proliferation, it formed the anterior median fissure. And the alar plate from the dorsal gray column here. Now, in case of cerebral cortex, the lamination occurs. Here, cells from the mantle layer proliferate and migrate in the form of waves. So, for example, the first wave of migration is from the sixth layer, second wave of migration from the fifth layer. In this way, the sixth wave of migration forms the first layer of cerebral cortex, which lies immediately beneath to the pia mater. So, in case of neocortex, the multiple waves occurs. That is why it is multi-layered and form the sulca and the gyre, right? In case of piriform cortex, 3 to 5 waves of migration occurs. That's why it is 3 to 5 layered. And in case of hippocampal cortex, only 3 waves of migration occurs. That's why it is 3 layered. Now let us see the third next process of morphogenesis, that is splitting and separation. So here the first example is the formation of extraembryonic xylem and splitting of intraembryonic mesoderm. So here we can see the extraembryonic mesoderm, it has splitted because of the appearance of the extraembryonic xylem here. So it is divided into 2 layers, that is the somatopleuric layer and the splanchnopluric layer, and it forms the chorion and the amnion, which are required for the parturition at the time of parturition as membrane here. Then in case of intraembryonic xylem, here we can see this is the notochord. Just lateral to this, here we can see this is the paraxial mesoderm. This part, this is the intermediate mesoderm, and this is the lateral plate mesoderm. In the lateral plate mesoderm, the cavity appears. Now again, this part, it is divided into 2 layers, the somatopleuric and the splanchnopluric mesoderm here. So this cavity, the intraembryonic xylem forms the cavity of the pericardium, then a pleural cavity and the peritoneal cavity. Now let us see the next process of morphogenesis, that is inclusion and embedding. The examples are the implantation of blastocyst and the embedding of suprarenal medulla into the cortex. So here we can see this is the blastocyst. Here, this is the embryonic pole which forms the future embryo. It receives the nutrition. It requires the nutrition. That's why it embeds first into the desidua. Then the remaining part embeds into the desidua here. Now, the development of suprarenal gland is the classical example for all the 3 processes of morphogenesis. These are the migration, inclusion and embedding, and lamination. So let us see how it is. So here, the fetal cortex develops by the migration of coelomic epithelium. Meanwhile, the neural crest migrates toward this part and form the medulla. Then the fetal cortex develops and the medulla embeds into the fetal cortex here. Here, the embedding of this medulla into the cortex is required because near about 80% of secretion from the medulla, it is adrenaline, and 20% it is noradrenaline. So to convert this noradrenaline to adrenaline, the methylation process is required, and for this, the blood rich in cortisol is required, and it comes from this cortex towards the medulla. That is why the embedding of medulla into this cortex is required. Then let us see how the lamination of cortex occur here. Here we can see in the core of this, the medulla is present. It is covered by the fetal cortex, and then cells proliferate and forms the definitive cortex. Then again, the definitive cortex separates into 3 layers from outer side to inner side. Here we can see this is the zona glomerulosa, fasciculata, and reticularis. So this is the way how the suprarenal gland is includes all the 3 processes of morphogenesis. Thank you.
Thank you, Dr. Shobha Madam, for such a wonderful session. Our next speaker, Dr. Mrinalini Vaksaure, is an assistant professor in the Department of Anatomy. She will speak about diverticulation, ingrowth, outgrowth, and septation. As we are trying to record the session as well, we will just allow it to save and then we'll continue further so that we can upload in as a small segments on YouTube. Just 1 second.
So good morning, everyone who is attending online and offline both. I'll be dealing with the next few morphogenetic processes, and those will be the diverticulation, ingrowth, outgrowth, which may or may not be associated with the excavation in and around. And the third one is a septation. So how do we define a diverticulation? It is an outpouching from a hollow viscous which contains all the layers from its parent origin, and it may be coming from a cavity or a tube. So this is an exhaustive list of the diverticulation. We are going to see few prominent examples amongst them. So start with the diverticulation which is forming in the yolk sac. In these two diagrams, we can see the changing sizes of the yolk sac. Initially, the primary yolk sac is quite large one, and along with the advent, the development of the extraembryonic mesoderm and extraembryonic coelom, the size of this primary yolk sac changes, and now it will be called as a secondary yolk sac. The primary yolk sac merely remains as a diverticulum coming from it. So that is a diverticulation of a primary yolk sac from the secondary yolk sac. The next is an example of chorionic villi, though it is forming by the ramification, but initially it is by the process of diverticulation. The cytotrophoblast, which is lining the continuous chorion, it sends multiple diverticula from it towards the syncytiotrophoblast and towards the decidua basalis, which first forms the primary stem villi, which will form the anchoring villi, and then by ramification they will form the floating villi. The next is the allantois. We know that the allantois, we often call it as a vestigial organ. It is developing from the dorsocaudal wall. So this diverticulation is developing from the dorsocaudal wall of the yolk sac, and it extends into the connecting stalk formed by the extraembryonic mesoderm. In case of lower animals and avians, the function of the allantois is to act as a reservoir for the waste material and also the organ of respiration. In case of humans, it has a function to direct the path of the umbilical arteries towards the placenta. It will remain as connecting the apex of the bladder to the umbilicus. Usually it atrophies, but if the lumen of the allantois remains persistent throughout its path, it forms the urinary fistula connecting the bladder to the umbilicus, from where the dribbling of the urine may occur. If it remains persistent somewhere in the middle, it will form the urachal cyst. And if it persistent only in the distal part, it will form the urachal sinus. Usually secretions are not coming out from this sinus. The next few examples of the diverticulation are in and around the developing brain. These will be the telencephalic vesicles, pituitary gland, pineal gland, optic stalk, and the vesicle. So let us begin with the telencephalic diverticulum. We know that the neural tube in the cranial region forms three dilatation, that is prosencephalon, mesencephalon, and the rhombencephalon. Amongst this, the prosencephalon shows two diverticula from the either side. These are called as the telencephalic vesicles. We can see them here. These are going to form the cerebral cortex and the corpus striatum of the cortex of the cerebrum. While the part which is popping out between these two vesicles
is known as the telencephalon impar, which is going to form the anterior wall of the third ventricle, and also it forms the preoptic nucleus of the hypothalamus. And we know that the hypothalamus comes from the diencephalon. The pituitary diverticulum, the anterior one, has already been discussed, which is an outgrowth from the stromatodium in the form of Rathke's pouch. So we'll see here how the posterior pituitary gland develops. We can see the outgrowth, or it is a diverticulation coming from the infundibular region, coming from the neurohypophysis, which is a part of the diencephalon. It comes down in contact with the anterior pituitary, developing gland, anterior pituitary. It will form the pars nervosa, stalk of the infundibulum and the median eminence, thus completing the development of the pituitary gland. The next is a pineal diverticulum. It develops as the diverticulum from the caudal aspect of the roof of the diencephalon. Later on, it becomes conical. In case of lower animals, it serves as a third eye because the retinal fibers are directly attached to the pineal gland. In case of humans, it acts as the biological calendar for the beginning of the onset of the puberty. In case of old age, it calcifies and forms the brain sand, which can be used to diagnose the midline shift on the CT and the MRI scans of the brain. The next is a diverticulation of the optic from the diencephalon, that is the optic stalk and the vesicle. We can see the diverticulation occurring, which has a proximal narrow part and the distal expanded part. The expanded part is known as the vesicle, while this proximal part is known as the optic stalk. The vesicle undergoes a differential change in the position and the shape under the influence of the lens placode and forms the optic cup. The two layers, this optic cup will give rise to the layers of the retina, and the optic stalk is remain as the optic nerve. The next example of the diverticulation is the membranous labyrinth, that is the lining of the inner ear. We can see the specialized surface ectoderm forming the placodes. You can see the placode over here. This is the otic placode, which forms the otic pit and then loses the contact with the surface ectoderm to form the otic vesicle. This otic vesicle undergoes a differential growth, first to form the utricle and the saccule. Then the utricle shows a diverticulum known as the endolymphatic duct and sac. The other diverticula will form the semicircular canals. From the saccule part, again a tubular diverticulum comes and it forms the cochlear duct. Now here I would like to specially mention the placodes, which are coming from the surface ectoderm. These are the specialized surface ectoderm. The ectoderm develops into the neuroectoderm and the surface ectoderm. While the neuroectoderm is going to form the central nervous system, the surface ectoderm again forms a generalized part and a specialized surface ectoderm. The specialized surface ectoderm in 4 places is important because it is forming the placodes. One which we have already seen, that is the otic placode. The next one is a lens placode, which will form the lens of the eye. The third one is the olfactory or the nasal placode. And the fourth one is the adenohypophyseal placode, giving rise to the anterior pituitary gland. An interesting part is mentioned in the textbook of Langman's. There are 4 lines which are present in the Langman. We can refer anyway to the book. The next example for the diverticulation is the membranous labyrinth we have seen. The tubotympanic recess forms the next example. The dorsal part, the first and second pharyngeal pouches, they form a diverticulation, which is a stalk-like narrow diverticulation in the proximal part and dilated part in the distal region. So proximal part remains as the pharyngeal, auditory tube, and the distal part forms the tympanic cavity along with the tympanic antrum. And it comes in contact with the first pharyngeal cleft. The ossicles, ear ossicles, which are developing from the mesoderm of the first and second pharyngeal mesoderms, that comes in contact and they invaginate this lining of the tympanic membrane, tympanic cavity, they are surrounded by this lining except at the attachment of the ligaments. So this invagination is similar to that of the lung buds invaginating into the pleura and the intestines invaginating into the peritoneal cavity. Now, if we see the previous figure again, the distal part of this tubotympanic recess and the proximal part of the first pharyngeal cleft, they are in contact with each other, which are separated by a thin layer of the mesoderm coming from the first pharyngeal arch. And these three components will complete the development of the tympanic membrane. The next is a paranasal air sinuses. These are developing as a diverticula from the lateral wall of the nasal sacs, and they will grow into the bones which are adjacent to the nasal cavity and form the maxillary, frontal, sphenoidal, and the ethmoidal air sinuses. The development of the thyroid has already been discussed, but just to mention, as the tongue is developing, there is a region called a tuberculum impar. From the caudal region of the tuberculum impar, the epithelial outgrowth occurs, which shows a depression and grows downwards to the anterior part of the neck, forming the thyroglossal duct. And this diverticulum will give rise to thyroid gland. Usually the thyroglossal duct disappears, but if it remains persistent, it forms the thyroglossal duct fistula, communicating the site of origin and the site of destination. Or it may form, if it is persistent in somewhere in its course, it forms the thyroglossal cyst, which moves with the protrusion of the tongue and also with the deglutition. The next is a respiratory diverticulum. It is a diverticulum coming out from the foregut region. In the pharyngeal arches, the sixth pharyngeal arch is flanking this diverticulum. The tracheobronchial diverticulum will grow downwards, and by a further process of ramification, it will form the parts of the respiratory system. The next is a hepatic and pancreatic diverticula. Hepatic diverticulum comes out from a point of a junction of the foregut and midgut. It grows into the ventral mesogastrium and soon bifurcates. The cranial division, which is a larger one, that forms the pars hepatica, and a caudal smaller division forms the pars cystica. The pars hepatica soon will again show two divisions, and they will form the parenchyma and the bile canaliculi of the two lobes of the liver. And the pars cystica will develop into the gallbladder. The proximal parts of these ducts will form the duct system of the two organs. Eventually, the pancreas is developing from the two diverticula, which are known as the pancreatic buds. This is a dorsal pancreatic bud, and this is a ventral pancreatic bud. They are developing from a region from where the duodenum will form. After the differential growth of the wall of the duodenum, these two ducts will come in contact with each other. Buds will come in contact with each other to form the various parts of the gland and also the duct system of the pancreas. The next example for the diverticulation is a Meckel's diverticulum. This is a remnant of the proximal part of the vitellointestinal duct. Usually, it remains attached to the distal part of the ileum on the antemesenteric border. As this is a part of the intestine, it will have the intestinal flora, and also sometimes heterotopic gastric tissue or the pancreatic tissue may be present into it. So if the inflammation occurs in the Meckel's diverticulum, it may mimic the appendicitis or the gastric ulceration, or it may be a pancreatitis. If the duct remains, the vitellointestinal duct remains patent throughout the length, it will form the fecal fistula at the umbilicus. The contents in the ileum will be discharged from this opening at the umbilicus. If it is remaining persistent in its course, it forms the vitelline cyst. If it is persistent only in the distal part, it forms the umbilical sinus, which will discharge the secretion from the lining epithelium and forms a differential diagnosis of the weeping umbilicus. Usually, it may remain as a cord, fibrous cord, along which the intestinal loops may be strangulated. The next is the vermiform appendix. We know that the cecum is developing from the diverticulation occurring from the post-arterial segment of the midgut loop. So the cecal bud, the proximal part is going to form the cecum, and the distal part will form the diverticulation from the cecum as the appendix. Later on, due to this differential growth of the cecum, the appendix will come to lie on the posteromedial aspect of the cecum. And the last example for the diverticulation is a processus vaginalis. This is a preformed sac of the peritoneum which grows towards the gubernacular mesenchyme of the inguinal and the scrotal regions, and the testes will invaginate this process from the behind, and after the process of the descent is completed, this processus vaginalis is going to lose all the contact from the peritoneal cavity and going to form the tunica vaginalis of the testes. If the communication between the processus vaginalis and the peritoneum remains persistent, it is going to give rise to various forms of the congenital hydrocele or the congenital hernia. We shift to the next process, the morphogenesis, that is by the ingrowth or outgrowth, which may or may not be associated with the excavation inside or out. We must remember that this is in relation to the mesoderm. If any growth is occurring towards the mesoderm, it will be an ingrowth. And if it is going away from the mesoderm, that will be considered as the outgrowth. So depending on that, we have multiple examples. We will see few of them. The notocard has already been discussed, but here, just to mention, the blastopore is extending its cavity towards the notochord, and this notochordal canal is formed till it will fuse with the floor of this notochordal canal to form the neuroenteric canal. So this is an example with ingrowth along with the excavation. The next example of the ingrowth with excavation around is the perivascular spaces in case of the brain. So here we can see a small section of the cortex where the vessels are entering into the subarachnoid space or leaving the space, which are surrounded by a space, and then they are lined by the pia mater. So these spaces are important for an easy conduit of the fluid in and out of the brain. Now, some of the glands, they are developing via a same method or same modus, that is the ingrowth of the epithelium towards the subjacent dermis. Usually, this epithelial layers will proliferate to form a solid cord, a cylindrical cord will go into the subjacent dermis, and later on it will be canalization occurring inside them to form the duct system of the gland. This holds true for the development of the sweat glands, the salivary glands, the sebaceous glands, and also the hair follicle. Just to mention, the sebaceous glands which are developing adjacent to the hair follicles, they are the examples of ingrowth without excavation in or around. The same example for the ingrowth with or without excavation is a diaphragm. We know the four sources which are giving rise to the diaphragm, that is the septum transversum, then the pleuroperitoneal membranes, the dorsal mesentery of the esophagus, and the fourth one, which is important here, is the ingrowth from the lateral body wall. If this ingrowth fails to occur, it will give rise to a condition known as the eventration of the diaphragm, which will form an outpouching to the respective thoracic cavity containing the abdominal organs. The next example for the ingrowth is the invagination of the heart tube. After the formation of the head fold, we know that the developing heart tube comes to lie ventral to the foregut and dorsal to the developing pericardial cavity. So these are the two heart tubes which are fusing with each other. They invaginate into the pericardial cavity from the dorsal aspect, so that the myoepicardial mantle which is surrounding these tubes will form the myocardium, and the layer of the pericardial cavity which is in the vicinity of these tubes is going to form the visceral layer of the pericardium. This pericardial cavity surrounds the heart tube completely except at the site of the attachment of the great vessels. The last example for the ingrowth is the intestinal crypts. Again, the same formula, that is the growth towards the mesoderm, is the ingrowth. So here the lining epithelium, which is derived from the endoderm, is shown, and below that we can see the mesoderm. So whenever the endoderm dips towards the mesoderm, it is going to give rise to the intestinal crypts. While if we see the intestinal villi, they are examples of the outgrowth without excavation. How is that? Because if we see the epithelium, it is growing towards the cavity but away from the mesoderm. So that is an outgrowth. And there are some stages for the development of the intestinal villi. First, there occurs proliferation of a villus ridge. Then there is delineation of the villus base and the definitive villus formation. This villi will have a pore of mesoderm invaginating into it, which will form the lamina propria and the muscularis mucosae. The example for the outgrowth, that is a limb development, which has already been discussed by the previous speaker. So this is just to enlist the list of the outgrowth. Then we go for the next example of the morphogenesis, that is a process of septation. The septa are arising as the growth from the wall of the cavity or the tube. Now this septation can be of two types, a negative septation and a positive septation. The positive septation is an active outgrowth. Okay, something is actually growing to divide the cavity, while the negative septation is the initial septum achieves the height by hollowing out of the cavities and thinning of the wall of the cavities. So we'll see some of the examples. The placental septation is an example of negative septation. We can see here the septa formed by the decidua, but these are not the true active growth. This decidua is initially very thick, but the growth of syncytial and the cytotrophoblast and the appearance of the lacunae inside the syncytial trophoblast, they go on enlarging and the decidua goes on thinning. So thus the decidual septae or the placental septae are formed by the negative septation. The area between the two septa is known as the maternal cotyledon. The next example of the septation is by the nasal septum. This is growth by both positive and negative septation. Why positive? Because the frontonasal process is actively growing towards the stomatodeum and also between the two nasal sacs. At the same time, the nasal sacs are enlarging to narrow down the frontonasal process. And ultimately, by narrowing more, the frontonasal process is going to form the nasal septum. The next example for the septation is the interatrial septum. So during entire fetal life, there is a constant need for diverticulation of the, diversion of the blood from the right side of the heart to the left side, since the lungs are not functioning. And this need is catered by formation of a septum in a sequence. The sequence is first there is formation of the septum primum, then there is a foramen primum, then occurs the foramen secundum, and the last one to come is a septum secundum. The septum secundum overlaps the septum primum with a gap remaining, that is called as the foramen ovale, which will be closed after the first breath of the newborn. If any sequence is hampered, it will give rise to the various types of the interatrial, the atrial septal defects. The next is the example of the septation, that is the interventricular septum. This is again the positive as well as the negative septation. First, the growth begins towards the floor of the ventricles, and the initial height of this muscular part of the interventricular septum is achieved by hollowing out of these ventricular cavities and thinning out of the wall of the ventricles, and the gap which is remaining between the upper part of the muscular part and the endocardial cushions is bridged by the active growth from the bulbar ridges, right and left bulbar ridges, and the proliferation from the endocardial cushions. Okay, so this is a active growth or positive septation. So interventricular septum is both positive as well as negative septation. Then comes the aorticopulmonary septum. We know that the truncus arteriosus is a common passage for the blood coming from the two ventricles. Now the septation occurs here by active proliferation of the truncal ridges and the bulbar ridges. They grow towards each other to form the septum, which is known as the spiral septum, in such a way that the blood from the right ventricle will go to the pulmonary trunk, and from the left ventricle it will go to the aorta. So this is a positive growth forming the septation. Okay, and the negative growth by the current or the stream of the blood coming from each ventricle. So this is a combined again example for the positive and the negative septation. Now, if the septation, the spiral septum is not forming at all, it will give rise to a condition known as the patent truncus arteriosus, which is a common pathway for the blood from both the ventricles. If the formation is occurring in a reverse way, it is going to give rise to the condition known as the transposition of the great arteries, meaning the pulmonary trunk will come out from the left ventricle and the aorta from the right. Then the third one is a shifting of the septum to one side, which is going to give rise to the overriding of the aorta. At the effect of this, it will form the pulmonary stenosis. The subsequent change will be the right ventricular hypertrophy, and to alleviate the pressure from the right ventricle, there is a foramen in the ventricular septum. So that is an interventricular septal defect. So all these four anomalies, that is the overriding of the aorta, pulmonary stenosis, right ventricular hypertrophy, and the VSD, they are forming a complex that is known as the tetralogy of Fallot. The next is a tracheoesophageal septum. The tracheobronchial diverticulum is developing in the floor of the pharyngeal arches, in the region of the sixth pharyngeal arch. From that, the diverticulum goes on the caudal side. The initial part communicates with the developing pharynx, but this diverticulum, as it goes downwards, will form the trachea, and it will be separated from the esophagus by formation of a septum, which is by proliferation of the mesoderm in that region to form the tracheoesophageal septum. If the septation is not occurring properly, it will lead to a condition known as the tracheoesophageal fistulae. The commonest one being the upper end of the esophagus ending as a blind pouch, and the lower end of the esophagus opening into the trachea just above the bifurcation. So the food from the upper part, which is, ingested by the infant, which may go to the trachea. The next is the esophagus opening by a single opening to the trachea. The third one is the both pouches are blind, but the upper one, opening into the trachea. And the fourth one is both the ends of the esophagus, they open into the trachea, and here the food may go from the above, the upper part, the mouth, or as well as, sorry, there's a regurgitation from the stomach to the respiratory system. The last example for the septation is a urorectal septum. In the region of the hindgut, the septum actively growing. This is a positive septation. Actively growing from the region of the allantois to the part of the cloaca. It will divide the cloaca into the ventral part known as the urogenital sinus, and the dorsal part is the primitive rectum. The urogenital sinus will give rise to the bladder and the parts of the urethra, while the dorsal part is going to give rise to the rectum and the anal canal. If there is any discrepancy in the formation of this urorectal septum, it will give rise to the rectum opening at different sides. These are the rectal fistulae. So in case of males, the rectum may open into the bladder. It may open into the urethra above or below the prostate gland. It may open, towards the membranous urethra, or it may open on the perineum other than the intestine site. In case of female, it may form a cloaca, one cloaca, which is having a common opening of all, that is the urethra, vagina, and the rectum. It may open into the rectum may open into the bladder, or it may open into the uterus, or it may open into the vagina, or an ectopic opening may be formed around the perineum. So in this session, we have seen the morphogenesis by three processes. First one was a diverticulation. The second was ingrowth and outgrowth. And the third one is by septation. I thank you all for patiently listening to the presentation, and please feel free if you have any queries to post in the WhatsApp group of the Demystifying Embryology. Thank you.
Yes.
Recording will be stopped for a few minutes, and after that it will start again. Thank you, Dr. Munali, for an informative session. Now it's my great pleasure to invite our next speaker, Dr. Shweta Bhatgare, Assistant Professor in the Department of Anatomy, to speak about fusion, absorption, incorporation, and obliteration.
Thank you, Shubhangi ma'am. Now we'll proceed further with morphogenesis by the fusion, absorption, and the obliteration. So we'll see this morphogenesis by fusion, absorption or incorporation, and the obliteration. So first of all, the fusion. So why fusion is important? One, the fusion is important or it is crucial for the correct formation and the functions of many organs and the tissues. Then for fusion to occur, the two opposing tissue components must approach one another and they should integrate to form a continuous tissue. If there is any disruption of this process, it will lead to the various variety of the human birth defects. Now, prior to the fusion, there is a prerequisite, that is the tissue must proliferate and position themselves in such a way that they are in opposition at right time and at right place for fusion to occur. So there are different mechanisms. They are conserved for individual tissues and some are conserved for the multiple tissues. But the main key mechanism for the fusion is the signaling pathways or the changes in the gene dose. So here are some examples of the fusion like this. Now we'll see this example one by one. So first one is the fertilization. As we know, fertilization is a complex sequence of the coordinated molecular events that begins with the contact between the sperm and oocyte and ends with the intermingling of the maternal and paternal chromosomes at the metaphase of the first mitotic division of his zygote. In this process, the sperm comes in contact with the three coverings surrounding the oocyte, that is the corona radiata, zona pellucida, and the vitelline membrane. Out of that, the direct contact of the sperm with the zona pellucida plays a major role before the actual fusion of the sperm and the oocyte. Now, if this fertilization fails, that means in vivo fertilization fails, then fertilization can be carried out externally in the form of in vitro fertilization. And this is carried out when there is oligozoospermia or the uterine tube blockage. Now, if there is inherent vitelline block, in that cases, we can directly inject sperm into the cytoplasm of a mature oocyte, and this process is called as intracytoplasmic sperm injection. Now, next example of the fusion is the neurulation. Now, we have seen the neurulation as an example of a migration, but here the main process by which the neural tube is formed is the fusion. How? The neural tube is formed by the fusion of the neural folds. The neural fold fusion starts in the midline and it extends cranially and caudally, leaving behind the two neuropores, that is the anterior neuropore and the posterior neuropore, which will eventually fuse on 25th and 28th day. Now, if there is failure of fusion of these two neuropores, it will lead to a variety of neural tube disorders. They are called as spina bifida. Now, spina bifida is of two types: spina bifida occulta and spina bifida cystica. Now let's see these defects. First one is the spina bifida occulta. In this defect, there is failure of fusion of the two vertebral arch It is simply covered by the skin. It does not involve any neural tissues, and it is characterized by the presence of hairy patch on the affected area. Next one is the spina bifida cystica. Now, spina bifida cystica is of three types: meningocele, meningomyelocele, and the myeloschisis. So first one is the meningocele. So it is simply the fluid filled cavity, that is the CSF filled cavity protrusion through the defect, and it does not involve any neural tissue but involves only the meninges, and that is the dura and the arachnoid matter. This one. The next one is the meningomyelocele. It involves the neural tissue. Then next one is the spina bifida with the myeloschisis. Schisis is simply cleaving. So in this case, the spinal cord is open and it is seen as a flattened mass of neural tissue seen on the affected area. Next one is the anencephaly. Anencephaly is due to the failure of fusion of the cranial neuropore, where you can see it is having the acrania, that is acrania, then this cerebral regression, and next one is the enlarged foramen magnum, that is ionencephaly. So in this, if these defects are having, most of the babies, they get spontaneously aborted, but sometimes these baby may take few breaths. Now, mystery behind this, though there is no development of a brain in these babies, but reticular formation is still there. That's why the babies are able to take few breaths. Now, next example of fusion is the formation of the face. Face is formed by the fusion of the two mandibular prominence, two maxillary prominence, and one frontonasal prominence. Now, these parts which are forming this, the two mandibular process fuse to form the lower lip and the lower jaw. The maxillary prominence fuse with the medial nasal process form this upper lip. Simply maxillary process prominence form this cheek. Frontonasal prominence contribute to the formation of the forehead, bridge, and the dorsum of the nose, and the lateral nasal prominence forms the ala of the nose. Next one is the formation of the palate. Palate is simply formed by the fusion of the primary palate and the secondary palate, but primary palate is contributed by the intermaxillary segments. This segment is formed due to the medial growth of the maxillary process, and the fusion starts on the surface as well as on the deeper level, and that's why this intermaxillary segment contribute to the formation of the upper philtrum of the upper philtrum area of the upper lip. Then it forms the upper jaw carrying the 4 incisor teeth and the small triangular area, that is the primary palate. Now, second one, the secondary palate or the definitive palate, it is formed by the palatine shelf-like process coming from the maxillary process, and initially its direction is obliquely downwards on either side of a tongue. But as the fusion continues, it attains its normal position, that is above the tongue, and it anteriorly fuses with the primary palate. So simply we can say that palate is formed by the fusion of primary palate and the secondary palate. Now, if there are any failure of this fusion of these components, it will lead to a various types of cleft lip and cleft palate anomalies. First one, this cleft lip anomalies. If two mandibular prominence fails to fuse, then it will lead to the median lower lip cleft. If two maxillary or medial nasal prominence fails to fuse, then it will lead to median upper lip cleft. All these these defects are very rare. The next one is, if medial nasal prominence fail to fuse with the maxillary prominence, it will lead to the paramedian upper lip cleft. It is also called as unilateral lip cleft. Next one is the cleft palate anomalies. Now, if primary palate fails to fuse with the secondary palate, it is forming this anterior cleft palates, and it is also seen on both sides, then it is called the bilateral anterior cleft palate. If palatine shelf fuse in the midline fails to fuse in the midline, then it will lead to the posterior median cleft palate, and if there is overfusion, then it is going to form the higher arch palate. Now, next example of fusion is the formation of the tongue. Tongue is formed by the fusion of the two lateral lingual swelling with the tuberculum impar and the hypobronchial eminence. This two lateral lingual swelling going to form the anterior 2/3 of the tongue, while the hypobronchial eminence is going to form the posterior 1/3 of the tongue. If there is any defect of the fusion between the two lateral lingual swelling, it is going to form the bifid tongue. Next example is the formation of the auricle. Auricle is formed by the mesodermal condensation of the masses called as auricular hillocks. There are 6 in number. Out of that, first one is contributed by the mandibular arch, and rest 2 to 6 are contributed by the rest of the arches. And if there are accessory auricular hillocks, and if they fail to fuse, then it's going to form the preauricular skin appendage. Next one is the formation of the primitive heart tube. This cardiac progenitor cells coming from the cranial 1/3 of the primitive streak, they migrate on either side of a primitive streak, and they arrange themselves in the form of crescent and forms the cardiac crescent. Now, during head fold, this cranial part of this cardiac crescent swings downwards to lie in front of newly formed foregut, and during lateral folding, as the lateral body folds, comes in the midline, it also brings the two limbs of the cardiac crescent in the midline, and the endocardial tubes which are formed in each side or in each limb of the cardiac crescent also fuse with each other and forms a single heart tube. Next one is the formation of the diaphragm. Diaphragm is formed by the fusion of 4 components, that is septum transversum, pleuroperitoneal folds, then the dorsal mesentery of the esophagus, and the muscular ingrowth of a body wall. If one of the component fails to fuse, then it will lead to the congenital diaphragmatic hernia. But out of that, the most common hernia is occurring through the posterolateral opening, that is called as foramen of Vogt-Dalek, and it is due to the defective pleuroperitoneal membrane which fails to fuse with the rest of the components. Next one, fusion is seen in the kidney, where fusion is seen between the nephron with the collecting tubule, and as there is a fusion, there is continuity between the collecting part and the excretory part. Disconnection between these two components is seen in the polycystic kidney. So polycystic kidney can be of 2 types, autosomal recessive and autosomal dominant. Autosomal recessive, where one gene is affected and is seen in children. Autosomal dominant, where both genes are affected, it's seen in the adult. So in these both cases, when the individual is susceptible one, then there is discontinuation between these nephron and the collecting tubule, and it will lead to the formation of the cyst. Next one is the formation of the uterus. Uterus is formed by the fusion of the 2 paramesonephric ducts, and these form the uterus. If there is any defect, it will lead to these various types of anomalies like didelphys, unicornate, bicornate, septate uterus. Now, during this formation, the paramesonephric duct catches the gubernaculum in between, and because of catching of this gubernaculum, it's going to form the 2 ligaments, that is the round ligament of uterus and the ligament of ovary. So it is going to hold the ovary in its place. Now, if you see this unicornate uterus, in this anomaly, as there is absence or the failure of this paramesonephric duct to catch the gubernaculum, the ovary will not be found in its original position, but ovary can be seen in the inguinal canal or the labius majus. Next one is the formation of the scrotum and the penis. Penis is formed by the fusion of the urethral fold, and the scrotum is formed by the fusion of the scrotal swelling. If there is any defect, then it will lead to the various types of hypospadias, except for the glandular one, which you will see in the apoptosis. Now, next one is the formation of the skull bones. In infants, the flat bones of the skull, they are separated by a narrow seam of connective tissue. They are called as sutures. If there are more than 2 bones meeting at one point, then sutures are wide and they are called as fontanelles. Now, if there is defect, or you can say the premature closure of these suture, it will lead to the variety of the cranial abnormalities called as craniosynostosis. So first one, when the parietal suture or the sagittal suture closes prematurely, then it will lead to the elongation of the skull, and it called as scaphocephaly. When the coronal suture fuses prematurely, then it causes the short skull called as brachycephaly. When the metopic suture of the frontal bone closes prematurely, it will lead to the anterior portion in the triangular pattern called as trigonocephaly. If one of the suture, that is coronal suture, prematurely closes on one side, it causes flattening of the skull, but it is asymmetrical one, then it is called as anterior plagiocephaly, and it applies also on the lambdoid suture, then it is called as posterior plagiocephaly. Next one is the formation of the vertebra. Vertebra are formed from the sclerotome tissue coming from the somites, and somites coming from the paraxial mesoderm. So in this case, the sclerotome tissue migrate in around this neural tube and the notochord, and at the same time it fuses with the sclerotome tissue of the opposing side. So this is the fusion. Next fusion occurring in the vertebra is the cranial sclerotome, or the cranial half of one sclerotome fuses with the caudal half of the or subjacent sclerotome. So these two types of fusion seen in the vertebra formation. Next one is the formation of the sternum. Sternum is formed by the mesenchymal condensation, and it's going to form the sternal bars. The sternal bars start to chondrify, and further it will ossify. Next one is the formation of the myogenesis. So multiple myoblasts fuse with each other and form a single muscle, but the main function of this is for the effective and the fast contraction of the skeletal muscles. Next one is the formation of the blood vessels. We have seen the formation of blood vessel by the blood islands, that is excavation. Now blood vessels also formed by the process of this this fusion, where the specification of the endothelial precursor cells occurs and they get differentiated into the endothelial cells, and then we form the small vasculogenic cords. These small vasculogenic cords fuse to form the small vessels, and small vessels further fuse with each other and form the long vessels. Next one, the type of fusion seen in the blood vessels, it is of three types: side to side, end to side, and end to end. So side to side fusion is seen in primitive heart tube. Then next one is when the two dorsal aortae fuse and they form the thoracic and the abdominal aorta. Two vertebral arteries join to form the basilar artery. Then examples of end to side fusion is seen in ductus venosus opening into the right vitelline vein, which is going to form the inferior vena cava in the adults, opening of the inferior mesenteric vein into the splenic vein, and next example, all aortic arch arteries when opening into the dorsal aorta. End-to-end fusion seen in palmar arch and the plantar arch. Now next, morphogenetic process is the absorption or the incorporation. So it is derived from the word absorptio, literally meaning process of absorbing or taking in, and it is seen in the incorporation of sinus venosus into the right atrium, incorporation of the pulmonary veins into the left atrium, incorporation of bulbous cordis into the ventricle, then formation of the foregut and the hindgut, and next one is the formation of the urinary bladder. Now when this right horn of the sinus venosus get absorbed into the right atrium, it is going to form the smooth portion of the right atrium. The pulmonary veins get incorporated into the left atrium and is going to form the four openings of the pulmonary veins. Then bulbous cordis get incorporated into the ventricle and it is going to form the outflow tracts of the both ventricle. Now all these three examples which are occurring in the heart, that is incorporation of the sinus venosus, pulmonary veins, and the bulbous cordis, these all are for the heart to make it as effective pump. Next one is the formation of the foregut and the hindgut, where when during this caudal fold and the head fold, the yolk sac is pulled inside or incorporated inside, and it is going to form the foregut and the hindgut. Next one is the formation of the trigone of a bladder. The mesonephric duct get absorbed into the, and it is going to form the trigone, and the rest of the part is derived from the mesoderm or the caudal fold, which get incorporated into the embryonic disc beyond the cloacal membrane, and if it fails to get incorporated, then it is going to form the extrophy of a bladder, where you can see the trigone of a bladder is exposed to the outside, anterior abdominal wall and the bladder wall are deficient, and pubic bones are widely spaced. Initially this condition was called as ectopia vesicae, but now it is called as extrophy of the bladder because there is eversion of a hollow organ. Next, third process is the obliteration. So literally meaning the blotting out, especially by filling of a natural space or lumen by fibrosis. The main mechanism responsible for the obliteration is the contraction of a musculature by mechanical stimuli or increased O2 tension. Now, type of obliteration seen in the blood vessels is the with persistence of obliterated structure, and second one is with disappearance of obliterated portion. So examples with persistence of the obliterated structure are umbilical artery, umbilical vein, ductus venosus, ductus arteriosus, and the left horn of the sinus venosus. Examples with disappearance of the obliterated portion are the part of right aortic arch and the ductus caroticus. Now let's see one by one. First one, this obliteration with the persistence of the obliterated portion. So after the onset of the respiration or the first breath of a baby, the four structures, this umbilical artery, umbilical vein, ductus venosus and the ductus arteriosus get obliterated and they form the remaining structures. The umbilical artery is going to form the medial umbilical ligament. Umbilical vein is going to form the ligamentum teres of the liver. Ductus venosus is going to form the ligamentum venosum, and the ductus arteriosus is going to form the ligamentum arteriosum. Now, the left horn of sinus venous also get obliterated and it forms the oblique vein of the left atrium, which opens into the coronary sinus. Now, next example, that is with disappearance of an obliterated portion. So, the part of the right aortic arch, which is between the fourth arch artery and the fusion of the two dorsal aortae, usually disappears. But what happens if it fails to disappear, then it will lead to a double aortic arch. So in this condition, the two structures, that is esophagus and trachea, get trapped between these two aortic arches. Now, second condition is the right aortic arch. So in this case, usually, normally the right aortic arch disappears and the left one persists. But in this case, there is reversal of this condition, hence this right aortic arch. And it also forms the anomalous right subclavian artery. Now, the portion of the dorsal aorta between the third arch and the fourth arch artery usually disappears on both sides. But if it fails to disappear, then it is going to form the part of the internal carotid artery. So these are the all examples of this obliteration. And in this session, you have seen these structures which are formed by the fusion, absorption, and the obliteration. And so this is the end. And if you are having any questions, please post it on the WhatsApp group. So we'll answer after one. Thank you.
Thanks, Shraddha, for such an enlightenment topic. Let's call upon our next speaker, Dr. Pampi Ranjan, Assistant Professor in the Department of Anatomy. She will speak about ramification, differential growth, and programmed cell death.
Thank you, Nagraj sir. So we have till this point, we have seen an in number of morphogenetic processes. Now I'm going to cover the last segment of today's morning session. I'm going to explain the ramification, differential growth, and programmed cell death, that is called apoptosis. So ramification, as we can see here, by definition, it's the repeated equal or unequal division of the branching of the terminal ends of the tubes or processes that is seen in bronchi, collecting tubules, and ducts. In embryology, following are the examples where we can see the ramification prominently. We will discuss each and every examples one by one. So talking about the first example of ramification is the placental villi formation. So we can see here, and already discussed in the previous lectures also, in previous slides, that the placenta has got a maternal rough side and a fetal smooth portion. This smooth portion is called the chorionic plate also, and the chorionic plate is self-diverticulum toward the maternal side. In this diverticulation, there is a core of cytotrophoblast, which is covered with syncytial trophoblast. The stem of this villi is called the stem villi or the truncus cori, which on further branching or ramification going to form the ramus cori and ramuli cori. This is how the ramification is occurring in placental villi formation. Moving to the next example of ramification is the bronchial system of the lung.
So we know that the lung develops as a diverticulum, laryngotracheal diverticulum from the foregut, initiation of the foregut, and it later get bifurcated to form two lung buds. This lung bud is going to form the definitive of the primary bronchus, and which later on branches and ramifies, going to give rise to the further generations of bronchial system. The one thing to mention here that the ramification which is happening here, the successive generation has got a diameter lesser than as compared to their parent one. And this will attribute to the laminar flow of air through the bronchial system. Little bit extension about the calculation of diameter of the generation bronchial tree. So the diameter can be calculated with this formula. The dr, which denotes the diameter of R generation of the bronchus, is equal to d naught multiplied by 2 raised to negative R upon 3. The dr denotes the diameter of the R generation of the bronchus, and denotes the diameter of the trachea, which is taken to be, for convenience, taken to be 12 millimeter. For example, if you want to calculate the diameter of the third generation of the bronchial system, so we just directly put in place of R, we are going to put the 3, and finally, as a diameter, we are going to get the value as 6 millimeters. So 6 millimeter will be the diameter of the third generation of bronchial system, that is the tertiary bronchus. Likewise, the diameter of 10th and 11th generation being 1.19 and 0.94 millimeter. Here, this 0.94 millimeter, which is supposed to be the 11th generation's diameter, indicates that this diameter is less than 1 millimeter, and this indicates the initiation of the bronchioles. Next example of ramification is seen in the collecting tubules of the kidney. So we know that the kidney develops from the metanephric blastema, while its duct system develops as a diverticulation from the mesonephric duct, that is called the ureteric bud. This ureteric bud ingrows inside the metaplastic blastema, and this is going to induce the further development of the parenchyma of the kidney. After getting into the metanephric blastoma, the ureteric bud bifurcates, and after that, branching further occurs to form the major calyces, minor calyces, and the rest of the collecting tubules. Here, one thing to mention that the superior ramification from the upper branch and the inferior ramification from the lower branch grows more vertically as compared to the middle branch, and that is supposed to be an important reason why the kidney attains a definitive shape, that it has got a length longer than its width. One more point to mention here that the ureteric bud, as I earlier mentioned, that it acts as an inducer for the development of the parenchyma from the metanephric blastema. So if there will be an absence of development of ureteric bud, or if it failed to engross into the metanephric blastoma, this will lead to a condition called renal agenesis. Ramification is also seen in the duct system of compound glands. So we know that the duct system arises as an ectodermal thickening, which ingrows into the underlying mesenchyme, and this grows down and branches further as a cord-like structure. So this branching is under the process of ramification only. Later on in the next segment, we will see how this solid cord-like structure is going to canalize to form the definitive duct system of the compound glands. Ramification is also seen in the process of angiogenesis, which is nothing but the development of blood vessels which from the pre-existing vessels. So before that, one thing to mention that how the pre-existing vessels or the vasculogenesis process has occurred. So we have in the initial lectures, we have discussed that vasculogenesis process happened by the aggregation of the mesenchymal cells, which are going to form the blood islands, which later get coalesce with each other, and finally cavitation occurs in that to form the primary vessels. Later on, budding and branching occurs from these primary vessels, which comes under the process of ramification only, and this is going to form the definitive blood vessels. This process is the angiogenesis. Coming to the next segment of morphogenetic process, that is called the differential growth. As the definition suggests here, that it is the difference in the growth rate of two organs which result into the change in their relation and the proportion. So in embryology, these are the few examples where we are going to find out the differential growth. We'll see the examples one by one. So the first differential growth is seen in the differentiation of trophoblast into cytotrophoblast and syncytiotrophoblast. So the trophoblast going to give rise to these two layers, out of which the syncytiotrophoblast growth rate is much faster as compared to the cytotrophoblast, and the growth is that much faster that it fails to exhibit the outer cell membrane and it appears like a syncytium. So that is why here also the differential growth comes into play, so that both the cyto and syncytiotrophoblast coming from a single parent, they are different in their structure. Differential growth is also seen in the second pharyngeal arch. So we know that the neck structures develop from the 6 pharyngeal arches, out of which the second pharyngeal arch overgrows on the clefts below and the arches below, and it further grows down to get fused with the lower structures. This will lead to the smooth contour of the neck. If the space between, generally the space between the second pharyngeal arch and the underlying clefts is appear as a cervical sinus. If this fails to obliterate, this will lead to pathological condition called branchial sinus, branchial cyst, or branchial fistula, depending upon the number of opening. If it will be having only single opening, it will be a sinus. If it will not be having any opening, it will be a cyst. If it will be having 2 openings, it will be a branchial fistula. Little bit more about the branchial sinus. Generally, the sinus has got single opening. It can be open, the opening can be interior or it can be on the exterior surface. If it will be present on the exterior surface, it generally opens on the anterior border of sternocleidomastoid at the junction of upper 2/3 and lower 1/3. And if it will be present interiorly, it opens on the tonsillar fossa. Differential growth is also seen in the brain vesicles. So the brain develops as a dilatation or as a diverticulation from the neural tube, from the cranial portion of the neural tube, as telencephalic, diencephalic, mesencephalic, and rhombencephalic vesicles. This vesicular growth is itself is an example of differential growth. Further, since the growth rate of the developing brain is much more faster as compared to the overlying growing skull bone, and to accommodate the faster growing brain, it flexes upon itself, leading to the flexures formation in brain. Moreover, if you see the lower slide, the telencephalic vesicles grows much more faster rate as compared to the diencephalon, and ultimately diencephalon get buried under the cover of overgrowing telencephalic vesicles. The similar story happens with insular cortex also. Initially, the insular cortex is seen over the superolateral aspect of the developing brain, but due to the differential growth, since the rate of the growth of the insular cortex is very slow as compared to the overlying cortex, that get buried inside the overlying cortex. This is also an example of differential growth. Moving to the next example, the heart, like the previous story, it also develops from an endocardial tube as a dilatation. So this is itself an example of differential growth. Later on, the developing heart is under the cover of a developing pericardium. The growth of this developing heart is much more faster as compared to the overlying pericardial growth, and that is why to accommodate itself, it gets flexed upon itself, leading to the folding of the heart. Differential growth is in GIT is seen in stomach. It appears as a fusiform dilatation from the foregut, again an example of differential growth. Here, one thing to mention that the borders, the dorsal border and the ventral border, they also grow at a different pace, and that is why the dorsal border grows faster, leading to the formation of greater curvature, while the slow growing ventral border going to form the lesser curvature of the stomach. Differential growth in the wall of the duodenum. So in this contents, one thing to mention that the differential growth of the wall of the duodenum leading to the definiting position of the pancreas. So we all know that the pancreas develops from the ventral and dorsal pancreatic bud, which arises at the junction of the foregut and midgut. These buds also develops with a different speed, and that is why the dorsal bud is relatively bigger as compared to the growth of the ventral pancreatic bud. Finally, during the development of the duodenal wall, rotation occurs, and this dorsal pancreatic bud undergoes a rotation of 90 degrees, while the ventral undergoes a rotation of 270 degrees, and finally takes a definitive position towards the left side and going to fuse with the dorsal bud to form the definitive pancreas. Here, the ventral bud is going to form a part of the head as well as the uncinate process, while the dorsal one is going to form the rest of the head, body, and the tail portion. In case of pancreas,
also differential growth is seen. The duct system of the pancreas grows with a slower speed as compared to the parenchyma, growing parenchyma of the pancreas. The parenchyma grows at a faster speed, and towards the tail region, finally the parenchyma lose contact with the growing duct system. And that is why this will lead to the formation of ductless gland in the tail portion. This is the reason why islet of pancreas are more concentrated toward the tail region. One anomaly which is related with the faulty fusion of the pancreatic bud is the annular pancreas. So here we can see here that the ventral pancreatic bud, before the fusion or before the differential growth of the duodenum, it got bifid, and it is during the rotation, it is going to encircle and finally going to fuse with the dorsal pancreatic bud. So it encircles the duodenum during the differential growth of the duodenum in a ring-shaped manner. This will lead to the constriction of the duodenum, and this condition is called annular pancreas. The symptoms will be like the duodenal atresia or duodenal stenosis. We have already mentioned how the cecum has developed from the caudal part of the midgut loop as a swelling. From that, a diverticulum-like structure arises that is forming the appendix. So initially, the opening of the appendix is situated toward the lower apical portion of the developing cecum, but during the process of development, differential growth occurs in the wall of the cecum, leading to the final and definitive opening of the appendix towards the posteromedial aspect. Differential growth in case of posterior wall of the urinary bladder. So we know that the urinary bladder major portion is from the urogenital sinus, anterior part, while the posterior portion is formed by the absorption of the mesonephric duct in it. Along with that, there is a diverticulation that is called ureteric bud that also got fused, and the fusion occurs in such a manner that both the openings are going to open at a common opening initially. But during the differential growth of the posterior wall of the bladder, the openings got separated, and finally the mesonephric duct, which becomes the ejaculatory duct definitive, they are going to open through the urethra at the neck of the bladder, while the developing ureteric bud, which are going to form the ureter, they are going to open on the superolateral aspect of the base of the bladder or the trigone. One anomaly which is related, somewhat can be related with the differential growth of the posterior abdominal wall is seen in case of double ureter. Double ureter is generally a condition where the ureteric bud either bifurcates before its invagination into the metanephric blastema, or there will be separate two ureteric bud which will be going into the metanephric blastema. Now, if double ureter will be formed, what will be the openings due to the differential growth? So the ureter which will be draining the lower pole of the kidney, that will be opening as usually on the superolateral aspect of the trigone. The mesonephric duct or the ejaculatory duct will be opening normally through the urethral opening at the neck of the bladder, while the part which is draining the superior pole of the bladder, which will be going to open in between two structures inferomedially. This is also due to the differential growth of the posterior wall of the bladder. Coming to the next segment of differential growth only, the gubernaculum testis. It is generally said that it is the shrinkage of the gubernaculum which is going to lead to the descent of the testis inside the scrotal wall. But it is not true. One of the important component of the descent of the testis is the differential growth of the anterior abdominal wall as compared with the slow growing gubernaculum. Gubernaculum is not growing at a faster speed as the anterior abdominal wall. So finally, during the end of the intrauterine life, the anterior abdominal wall grows faster, and as compared to that, the gubernaculum doesn't grow as much faster, and this will lead to the relative shortening. And finally, it is one of the contributing factors for the descent of the testis from abdominal cavity to the scrotal wall. So it is not actually the shrinkage. Omphalocele is a condition, surgical condition, which happens due to the failure or fault in the differential growth of the abdominal wall with relation to the intestinal loop. So it is seen that initially the developing midgut loop fails to get accommodated inside a limited capacity of the abdominal cavity. So it comes out from the umbilical opening towards the anterior abdominal wall. As the development progresses, the anterior abdominal wall grows further and the cavity becomes sufficient to take the intestinal loop. So the loop comes back through the umbilical opening. So if there will be any fault in the development of the anterior abdominal wall, or there will be any discrepancy in this differential growth, this will lead to the failure of the reposition back of this herniated intestinal loop, which generally happens at 10th week of intrauterine life. And this will lead to a protrusion of intestinal loop, which will be covered by a cover of amnion. This condition is called omphalocele. So this occurs due to the faulty development of differential growth of the anterior abdominal wall with relation to the viscera, abdominal viscera. Last example of differential growth is being the growth of the spinal cord within the vertebral column. So the spinal cord develops from the caudal portion of the developing neural tube. Initially, till the third month of intrauterine life, the growth coincides with the growth of the vertebral column, which is overlying over it. But as the age progresses, the growth slows down, and its growth, the adjacent vertebral column growth remain faster as compared to the developing spinal cord. So it appears receding, and the level of termination appears receding back. So at the time of birth, the recedence happens in such a way that the spinal cord ends at the level of L3 vertebra, while in the adult phase, again, due to the faster growing vertebral column and the rate of the slower growing spinal cord, the level ends at the lower level of L1 vertebra. This happens due to a difference in the growth rate of the vertebral column and the spinal cord. Moving to the last segment, that is the cell death. So we know that the cell undergoes a aging process, and these aged cells should be removed from the body. And this removal of the cell generally happens by a programmed process that is called apoptosis. There is one more form of the cell death that is called necrosis, which occurs if there is a provocation from the carcinogenic substance or infection or inflammation. So let's see few examples, few differences between necrosis and apoptosis. If the cell during the death process enlarges, this is the characterization of necrosis, while in apoptosis, generally cell shrinkage is seen. In case of both these processes, the nucleus substance shrinkage, it fragments and it finally undergoes lysis. So pycnosis, karyorrhexis, and karyolysis are seen in both the processes. In case of necrosis, the cell membrane disrupts, leading to the scattering of cytoplasmic content outside. And probably this is the reason why the inflammation is associated with necrosis, because of the scattering of cellular contents. While this cell membrane remain intact in case of apoptosis, so that is why inflammation is not at all seen here. Further, in apoptosis, there will be a membrane-bound fragments we can see, and that is called apoptotic body. So this picture depicts the fragmented apoptotic body, which are covered with cell membrane. These are few of the examples in embryology where apoptosis are generally seen, that is programmed cell death is seen to decrease the number of aged cells. First example being the renewal of the cell of the skin and mucosa. Our skin and intestinal mucosa are the fastest growing cells, and they ages faster as compared to the other cellular structures of our body. And thus replenishment or the removal of dying cells occurs by the process of apoptosis there. This apoptosis is also important because it prevents the production of cancerous cell in our body. Moving to the next example of apoptosis is the ovarian follicle. During the intraembryonic life, there are millions of primary oocytes which are developing. And till the birth, when the birth happens, the number recedes back, and it will be approximately around 2 million primary oocytes which are there in newborn female. So why the recidence happens? The recidence is happening due to the apoptosis. The some cells get die, and the decrease in number of primary oocytes occurs. And this will indicate that when the person or the female reaches up to puberty, only 40,000 of the primary oocytes remain functional. Out of these, only 400 will ovulate during the entire reproductive life of a female. The remaining cells get atretic or they die by apoptosis. Now, apoptosis is also seen in the canalization of the duct system of the gland. Till this point, we have seen that how the cord-like structure grow, epithelial cord-like structure grow under the mesenchyme, and they branches by ramification. And further, this solid cord-like structure get canalized by the process of apoptosis, leading to the formation of definitive duct system of the glands. Same thing is seen in nasolacrimal duct formation also. If failure of apoptosis occurs, which will lead to the prevention of the canalization. This will lead to a condition called nasolacrimal duct atresia. Joint formation. Synovial joint formation is also an example of apoptosis. So here there is a mesenchymal bone model, which in the interzone region get modified and get compacted. Finally, apoptosis occurs in interzone region, leading to the gap formation, which is further going to form the synovial joint formation. If this gap get filled or occupied by fibrous tissues, it is going to form the fibrous joint formation. If it gets occupied by the cartilaginous tissue, this is going to form the cartilaginous type of joint. Apoptosis is also seen in the disappearance of the oropharyngeal and cloacal membrane. So we know that the oropharyngeal membrane is a place where ectoderm and endoderm are lying in close proximity without the underlying mesenchyme. Mesenchyme is the source of blood vessels. So if it is deficient here, the vessels, the layer will not get proper nutrition. Finally, perforation occurs, which coalesce to form the disappearance of this cloacal or the oropharyngeal membrane, leading to the definitive oral cavity, definitive anal cavity and oral cavity respectively. If some defects occurs in the apoptosis of cloacal membrane, this is going to lead to a condition that is called imperforate anus. Apoptosis is also seen in the disappearance of webs, notching in the web spaces or the mesenchyme in the web spaces. So earlier we have seen how the limb buds are formed by an ectodermal proliferation, and in that the mesenchyme proliferate to form the digital rays with the presence of notching in between them. That notching get occupied or get filled up by a loose mesenchymal tissue. Further, in the definitive formation of the fingers, these loose mesenchyme get disappeared by the process of apoptosis. If these mesenchyme fail to disappear, or suppose there will be absence of apoptosis, this will lead to a condition called cutaneous syndactyly or webbed fingers. If during the notching process, more number of notches are seen, this will result in the formation of more than 5 number of digits, which is generally 5 number of digits are generally seen in human bodies. So if more number of notching will seen, more number of digits will be there, and this condition will lead to a condition that is called polydactyly. So this is indicating polydactyly. Apoptosis is also formed in the seen in the formation of foramen secundum. So we have seen in earlier slides how the septum and foramens are formed. So initially the septum primum is growing down, leading to a formation of foramen primum. Finally, perforations are happening here with the process of apoptosis, and this will lead to the formation of foramen secundum. Now this slide seems to a complex one, but for convenience, this is the part of the thymus. This is the cortical portion. This is the medullary portion. This diagram depicts how the lymphocytes are generating, and finally, after maturation, they are moving back towards the medullary region to enter into the circulation. Here, one thing to mention, approximately 99% of the developing lymphocytes which are developing in the cortical region, they fail to come back towards the medullary region and fail to come into the circulation. They get apoptosed because only these 99% are responsible for the formation of autoantibodies in our human body. Only 1% moves and matures and comes to the medullary region to come into the circulation, becomes functional lymphocytes. So 99% which are responsible for autoantibody formation, they get apoptosed, preventing the body from autoimmunity. We have earlier mentioned that at 2 places in our GIT, recanalization is seen. Initially, the gut tube is hollow, but due to epithelial plug formation, it gets occluded. And finally, due to apoptosis process, these lumen get canalized. These 2 processes are seen in case of esophagus and duodenum. This is occurring by the process of apoptosis only. If apoptosis fails to occur or partial apoptosis occurs, this will lead to a condition called duodenal atresia or esophageal atresia or duodenal or esophageal stenosis. Apoptosis is also seen in sino-vaginal bulb. So before that, I want to conclude that the vagina is formed by the fused lower portion of the paranasal picture, that is called the uterovaginal canal, and the lower part is formed by the urogenital sinus. These urogenital sinus are going to send to sino-vaginal bulb, which are going to fuse to form the vaginal plate. This plate is solid. Later on, by the process of canalization, this
plate gets hollow and the vagina gets in continuity with the upper cervical region and finally lead to the definitive vagina formation. If apoptosis becomes faulty here and the vaginal plate fails to apoptose or fails to canalize, this will lead to a condition called vaginal atresia. Moving to the last slide of today's first session is that the development of the glandular urethra. So earlier we have seen how the spongy urethra is formed. Later on, from the glans penis, ectodermal cord, solid ectodermal cord grows inside the substance and it gets in continuous with the spongy urethra. Later on, this cord, solid cord, is getting apoptosed and forming the definitive glandular urethra of human body. So if there will be any abnormality in the apoptosis process, this glandular epithelium or glandular urethra fails to form, and finally the urethra will have been the opening on towards the junction of the body and the glans penis of the developing external genitalia of male. So this condition will lead to a phenomenon that is called hypospedia, where the opening will be lying on the ventral surface. So here this apoptosis is also important because it leads to the canalization of the glandular urethra. And this is all from my side. So we have described about the ramification, the differential growth, and the programmed cell death. Thank you all for being so patient, and you can put your queries in the box.
Thank you all for attending it. Thank you, Dr. Pompey, for enlightenment of this topic. Now we will look into the questions, but there are any questions hardly, so we'll take with the lunch break. We will now join at 1:45 p.m. for after lunch session, which will be taken by guest speaker Dr. Yogesh Sontake sir for student. So we will take a lunch break and join at 1:45 p.m. Thank you. So the delegates from the
हे जरा हे कर. मागे कर.
तर तुम्हाला कसं वाटतं बघा सांगा त्याच्यानुसार मी शकतो.
हे इथे आवाज इथे आवाज. Good afternoon, ladies and gentlemen. I, Dr. Sumit, welcome you back after the sumptuous lunch break. Our post-lunch session is dedicated to stem cells, which is a hot and burning topic of discussion and will keep your postprandial slumber away. It's my pleasure and privilege to introduce our guest speaker, Dr. Yogesh Sontake, sir. Dr. Yogesh Sontake is currently working as an additional professor in Department of Anatomy, JIPMER, Puducherry, and has a vast teaching experience. After completing MBBS from GMC Nagpur, he has done his MD in Anatomy from Jawaharlal Nehru Medical College, Wardha. Do not follow where the path may lead. Go instead where there is no path and leave a trail. Practicing this philosophy, Sir has published many textbooks like Textbook of Human Anatomy, Human Embryology, Human Histology, Principles of Clinical Genetics, Principles of Histological Techniques, Immunohistochemistry and Microscopy, Principles of Scientific Writing, and MCQ, and also Viva in Human Embryology. Apart from his exhaustive list of textbooks, he has 52 publications in national and international journals to his credit. He is editor and also appointed as a member of editorial board in many national and international journals. I invite Dr. Yogesh sir with a floral bouquet by Dr. Kavita. Sir, please.
Good afternoon, everyone. I'm very happy to see the smiling faces. Just traveled to meet all of you. The topic allotted for me is the stem cell. Before going to start discussion about the stem cell, one thing I want to share. Once upon a time, my teacher used to say they have read a human body is having 56 chromosomes. I read that the cells in the human body are having 46 chromosomes. So science is changing continuously. The things which looks bigger today, they will not be that much bigger tomorrow, because we are continuously walking towards the developing science. Today, the field of stem cell is very big. We feel that it is a very big thing, something big thing is going on, and we are not aware of that. But tomorrow, it will become very small things. When we were the undergraduate students, that time, polymerase chain reaction, PCR testing for genetic analysis, it was a big thing. But slowly now PCR testing is becoming now day-to-day life investigation. We are analyzing single polynucleotide polymorphism, SNPs we are searching. We are having next-gen sequencing, and lot of things are changing now. Due to the advancement of the infrastructures, government is continuously focusing on development of more and more stem cell research lab, more and more blood banks. They are continuously promoting the research towards the further development. I can understand our country is a developing country. Still, we are little bit behind in science than many other countries. But if we see even the developing research, mostly the Indian scientists are sitting in the developed lab in the world and they are doing the research. So coming to the stem cell, before that one, I want to say thanks to Professor Shamkishore sir, Professor Dr. Yuvraj, Nagraj sir, Shubhangi ma'am, and entire Department of Anatomy and organizing team for inviting me for this guest lecture. When we say the stem cell, lot of questions are coming in mind. So what are the questions like what is stem cell? What is the embryonic stem cell? What about the adult stem cells and human cloning? Is it possible to clone the entire human using the stem cell? Lot of questions are there. When questions are there, rumors will be there. Due to the lack of the knowledge, many times we hear something the wrong information. So today I want to discuss about these questions and I want to answer and want to clarify these things actually. When we say the stem cell, research, rather than research, we are more concerned as a doctor towards the therapeutic uses of the stem cells. So stem cells are present in my body, your body, and everyone's body. So they are nothing, something big, which is there only in the laboratory. No, they are us, they are within us. So what is the stem cell? It is nothing but a cell which undergoes the self-renewal. The self-renewal is the first property of the stem cell. It is the ancestor, it works like an ancestor for the other developing cells. It can differentiate and forms the other differentiated cells actually of the body. One blood stem cell can give rise to the red blood cell, white blood cell, and a platelet like that. So that are the stem cells. So what are exactly the properties to be fulfilled by the cell to say it is a stem cell? Self-replication, as I told, self-replication is the prior property, first property of the cell. Then it should have the capacity of the differentiation, commitment towards one particular function. So that commitment is required. So capacity of the differentiation or the potency is the another property. Then it should have the capacity to replace the other cells. Like suppose in human body, there are certain cells which work as the stem cell. For example, the basal cells in the lining epithelium of gastrointestinal tract, they continuously multiply and they replaces the remaining damaged cells of the human body. So that property should be there in the cell to say it is stem cell. The cell should be uncommitted until it receives the proper signal to form a particular cell, undifferentiated. We cannot say it is a particular cell. We cannot say it is the lymphocyte or monocyte unless and otherwise one stimulus comes to that cell and that stimulus signals comes and says that differentiate and form a particular cells. The stem cell should be immortal. This is questionable mark actually here. Immortal. The cell should multiply throughout our life, but it is not like that one. The cell's multiplication should, though we say that the stem cells are immortal, but they can multiply only up to 30, 40, 50 cycles. After that, the stem cells will die. So like that, this property is the ideal property of the stem cells, which may not be there in all types of the stem cells. That's why we should understand what are the different types of the stem cells and what are their properties. Earlier speakers already covered this topic, but still I want to focus more towards the stem cell research here. The totipotent cells. I have suppose developed one lab, and in that lab I want to do the stem cell research. Which cells I should utilize? Can I use totipotent cells? Can I use pluripotent or multipotent? That question will be there in the mind. So which cells are useful in the stem cell research or stem cell therapy? So for that one, we have to understand totipotent cells. In the human body, when there is a zygote or the morula, that each and every cell of the morula has capacity to generate the entire human body, including placenta, including umbilical cord. So if the cell is having the capacity to form the entire human being, including placenta and umbilical cord, such a cells are called as totipotent cells. We should not use such a cells for the stem cell research. Then there are the pluripotent cells. These pluripotent cells can multiply and form many differentiated cell types, except the pluripotent cells cannot form back the totipotent cells, or they cannot form the placenta. When we see the trophoblast, which is the outer coating, inside the trophoblast, inside the blastula, there is the inner cell mass. This inner cell mass is particularly a pluripotent stem cell that has capacity to form the entire embryo except placenta. It cannot form the placenta. So these cells are the targeted cells. Currently, they are in use for the stem cell research. You understand what I am saying? Not for stem cell therapy. I am saying stem cell research. These two things are different currently. Stem cell research is going on, which is different, and stem cell therapy is different. I will explain what is the therapy available right now and what is the research going on. Then multipotent cells are there. They can form the discrete type of the cells. For example, hematopoietic stem cells, which can differentiate to form the different blood cells. Some are oligopotent cells or progenitor cells. They can give rise only to the few type of the cells. For example, lymphocyte precursor cells, they can differentiate into T or B lymphocyte only. Or unipotent, they can form only one type of the cells, such as the hepatocytes. Hepatocytes can multiply. Suppose one person, we have removed a part of the liver. He is having carcinoma. We have removed a part of the liver. We know the biggest actor in the India, Amitabh Bachchan. We have surgeons have removed a part of his liver, but now he is alive and he is performing well because his liver cells have replicated. The entire liver is there in his body right now because the hepatocytes have capacity to regenerate the liver. Such a cells are called as the unipotent. They can multiply and form only one type of the cells. So what is our target for stem cell research now? Inner cell mass. The cells which can form the multiple things. And another is the multipotent. These two cells are our target. One is the pluripotent and another is the multipotent cells. Multipotent cells can form different kinds of the cells in the human body. Out of these, pluripotent cells are for research and multipotent cells are available right now for the therapeutic uses. We do not use pluripotent cells for the therapeutic use right now, but multipotent cells are permitted in India. So here we can see there is a totipotent cell. This is the totipotent cell, which that is the zygote up to the stage of the morula. Up to first 3 to 4 days, that cells have the capacity to generate the entire fetus. But after that one, this inner cell mass are the embryonic stem cells. Which are the cells? Embryonic stem cells, ES cells, embryonic stem cells, and this is the targeted cells actually. How we can get these cells? We need the fertilized ovum. We need ovum. We need sperm. We need the center where we can fertilize the ovum. We can need the facility to multiply this one in the form of the morula, and these are commonly present in IVF centers, in vitro fertilization centers. Lot of private in vitro fertilization centers are there. So like that one, if the government institute or the medical college, if they have the facility of the IVF in that center, if some unutilized this embryos are there, that we can utilize for stem cell research. And after that one, in the adult life also, some cells are there. They are the multipotent cells. In the adult life, pluripotent cells are not there, but multipotent cells are there. And that cells we can utilize in our body, bone marrow cells, multipotent. They are multipotent cells. And that cells we can utilize for the therapy also. So when we come to the classification of the stem cells, we can classify into two groups. One is the embryonic and another is the adult stem cells. So what are the sources of the stem cells? One is the embryoblast, one is the umbilical cord blood cells, teratoma cells. Teratoma is the cancer which is having all three germ layer cells. Then bone marrow cells, liver, epidermis, retina, skeletal muscle, intestine, dental pulp, aborted fetuses, placenta and amniotic fluid. They have the different types of the stem cells. We have to choose a particular cells depending on our purpose. What is the difference between the stem cell and a progenitor cell? The stem cell can give rise to the variety of the cells, but progenitor cells gives rise to a particular group of the cells. Only few type of the specialized cells can be given arise from these progenitor cells. Example of the stem cell in the adult human body, if you say hematopoietic stem cell. In the adult body, the stem cells, which are the hematopoietic stem cells, they can give rise to the various sorts of the blood cells. But myeloid progenitor cell, these are specifically, they can give rise only to the neutrophil and RBCs. So they are the progenitor cells. So our target is to utilize the hematopoietic stem cell and not the progenitor cells. Fertilized egg. Actually, this is the best to provide all the stem cells. It is truly totipotent. That means it can give rise to any number of the cells, but we are not using fertilized egg. We are using only the stem cells which are coming from the inner cell mass. So inner cell mass can give rise to the wide range of the tissues. Only after fertilization, 5th day after fertilization, before implantation. When implantation occurs, 6 to 7 days. Okay, various depending on the condition. So before implantation, we have to take that fetus and we have to take that blastocyst, and then from that one we have to extract the inner cell mass, and that can be utilized. The property of this inner cell mass is it can be grown indefinitely. It can be grown for a multiple cycle, n number of the cycle. One cell can multiply. They are the immortal cells. Unless and otherwise we stop its multiplication, they keep on multiplying and they retain the property of pluripotency. They should not lose the property of pluripotency. What is pluripotency? Means one cell is forming the different sorts of the cells. That is the property. It should not happen. The cell is continuously multiplying, but it is not able to differentiate into some other type of cell. So differentiation property should be retained during the multiple cycle, cell cycle. So that property will be retained properly by the stem cell, embryonic stem cell. When we go to the IVF lab, this is very common pictures for them. Like histology lab, you might have seen the cells, but they are seeing the developing embryo. The first diagram is the zygote here, and this is the 2-cell stage. Then this is the 4-cell stage, this is the morula stage, and after that, this is the blastocyst. This is the pre-implantation, day 5, and this is the inner cell mass. This inner cell mass we can remove from this blastocyst using the micromanipulator. Using micromanipulator in their laboratory, they will have the facility for collecting the sperms, collecting the ovum, and doing the IVF, in vitro fertilization. They will use one petri dish In that one, they will put sperms, ovum, and they are going to make it fertilize. They will see the results under the microscope. They will keep it for incubation at 37 degree in CO2 incubator. Why 37 degree? Because these are the human cells. They retain all their chemical properties. Cells are having enzymes. Cell is having DNA. So all enzymatic activity and other activities are well performed at 37 degrees centigrade. So all stem cell laboratory should have the CO2 incubator, which can maintain the temperature at 37 degrees centigrade. Carbon dioxide is the stimulator for the cell division. That's why they utilize this carbon dioxide. If you see the fallopian tube, the concentration of the carbon dioxide within the lumen of the fallopian tube is little bit less actually. So maybe 3 to 5%. So 3 to 5% of the carbon dioxide concentration should be there in IVF center during the fertilization and incubation. And these cells, they keep it in the culture media. Fertilization media will be there, culture media will be there. Like we need nutrition, these multiplying cells also need nutrition. Suppose in one dish, they have added the cells has property to settle down. The cells will be usually in the bottom of the petri dish or bottom of the fertilization tube. So we can easily remove, if we tilt the plate, we can easily remove the culture media and we can add the new nutrition. For example, I am saying that this inner cell mass we need to remove from this blastocyst stage on the day 5. So for 5 days, we cannot keep the same culture media. The culture media will be utilized by the cells for nutrition. They need amino acids. They need nucleotides for their replication. They are replicating cells. They will replicate their DNA very fastly. So for that one, continuous supply of the amino acid, nucleotides, proteins, other carbohydrates, it will be required. So we need to change continuously the culture media. So in the stem cell research laboratory, culture media and all these things will be required. One more thing, we should not inoculate any bacteria or virus. Any infection should not enter during this culture processing. So we need the laminar airflow to prevent the entry of our nasal bacteria or the bacteria which are circulating in our respiration. We open that bottle or the culture media. Our bacteria should not enter in that one. Otherwise, bacteria will multiply more than our cells. Our cells requires at least 72 hours for the cycle, one cycle to complete. They may need only 1 hour to complete their life cycle. So bacteria will multiply more. So all aseptic precautions will be required in the laboratory. So our target is to isolate this inner cell mass and to utilize it for our stem cell research. Why blastocyst only? Why not other cells? That also we need to understand. Stem cells obtained from this blastocyst, they do not have any body plan. Unless and otherwise there is the formation of bilaminar germ disc and formation of the primitive streak. Body plan is not designed properly. Before that one, even a single cell if you remove, it can form the entire embryo. Okay. So many times scientists want to know the genetic constitution of the fertilized fetus, actually fertilized developing blastocyst. So they may remove one single cell from this blastocyst, nothing is going to happen. Only if they remove carefully. Do you think that can we remove only one single cell? Have you heard the word intracytoplasmic sperm injection? So if we can inject a nucleus or we can inject a sperm into the ovum, of course, that is very small. This is a very big cell. Sperm is very small. Injection of the sperm, if it is possible, removal of one cell, definitely it is the easier task than the intracytoplasmic sperm injection. This is more easier. So yes, it is possible. We can remove one cell and from that one, we can analyze the DNA of that one. Okay. So blastocyst cells we are utilizing because body plan is not yet designed, and that is the most important thing. So that cells is having pluripotency. We can utilize that cells to develop anything. So there is no precursor of the nervous system till the stage of the blastocyst. embryo does not yet necessarily represents the unique individuals. Up to the day 14, the unique individuals is not yet defined. So these cells we can utilize. What are the advantages of the embryonic stem cells? Embryonic stem cells can multiply easily. If you provide the nutrition, if you provide the carbon dioxide, if you provide the proper 37 degrees centigrade atmosphere, they can multiply easily. Suppose in one petri dish, one embryo I have taken, after 1 month, 2 months, I may have hundreds of the petri dishes or hundreds of the cell culture bottles, which will have thousands of the cells. For the treatment, the number of cells is very important. For example, suppose I have transmitted some stem cells in one patient body, definitely they will have the lifespan. Outside, they will have certain lifespan. When we inject it, after 3 months, after 6 months, patient may be in need of more stem cell. That time from where we will bring. So stem cell continuous supply should be there. So these embryonic stem cells can provide a continuous supply of the stem cell for our patient for n number of the cycles. Have you heard chemotherapy, 1 cycle, 2 cycle? Like that, stem cell therapy should be there in the cyclic form. Patient may need 10 cycles of the stem cell therapy. So continuous supply of the same type of the cells will be required. That's why embryonic stem cells are better. They can generate the every cell type, whatever cell we want, that can be generated. They are immortal. N number of cycles we can use them. They can be manipulated for developing desired cells. We can provide some interleukins, we can provide some chemicals which will induce their differentiation in a particular cell type. For example, suppose we have a bone marrow surface, we have cultured bone marrow surface in a one dish, and then if we lay down the stem cells on them, they will get converted into hematopoietic stem cells. So here we are producing them the stimulator. Some stimulator will be required, some proper environment will be required. So if we provide that artificial environment to the embryonic stem cell, they can be converted to the another type of the cells, which will not be that much possible in the adult stem cells. But there are certain disadvantages. They are difficult to differentiate uniformly. Suppose stem cells are there, out of 10 cells, some will become bone cells, some will become cartilage cells. So we cannot easily control their differentiation. So that is the biggest problem we are facing during the embryonic stem cell cultures. They are immunogenic. They may rejection. Due to the immunogenic response of the individual, the rejection chances are more for embryonic stem cells. Then they are tumorogenic. They may form the teratoma, which is uncontrolled cell differentiation. And ethically, there is a need of destruction of the fertilized embryo, blastocyst. We are going to destroy. So is it ethically correct? It is very difficult to say that we are taking one ovum, we are taking one sperm, we are forming one embryo, developing embryo, and we are removing the inner cell mass for our purpose. So once the ovum is fertilized, we should say, yes, it is the life, one new life, and we have to destroy that new life. So how much it is ethically correct, that is questionable. There are certain other disputes also I will discuss afterwards. So embryonic stem cell, which is obtained from this inner cell mass, and then after that, at the end, we will produce some cultures. So how these cell cultures can look like? So here we can see that this is the cell cultures and this is the embryonic stem cells, inner cell mass. And after 10 to 15 days, it will look like this one. This is the embryonic stem cell culture, which looks like this under the microscope. They are unstained cells. So for that one, we need one inverted microscope. Inverted microscope is required because I initially told the cells has property to settle down in the culture. So once the cells are settled down, like we are seeing the microscope slides from the objective, which is coming towards the slide from the above. But here the cells are in the bottom, and above that one flask is there. Our objective cannot reach the cells because of the culture media. So the flasks are made with such a thickness that we can see the slides from the below. So inverted microscope is the another basic requirement for stem cell culture lab. So coming to the next type of the cell is the pluripotent stem cells. They grow indefinitely in the vitro, pluripotent stem cells. They can maintain the normal karyotype. This suppose 46 chromosomes are there, that will be well maintained in them, and they can be cloned for few cycles, and they will have the capacity of differentiations into a particular cell. Then coming to the characterization of the primate, this pluripotent stem cells. Actually, this research is going more there. Embryonic stem cells and pluripotent stem cells, mostly this research is going in the animal models. Which cells we can say that they are the these cells actually? For that one, TRAI 160, that is the one marker which we can use to differentiate, to identify this particular cell. Then epitopes, SSEA3 or SSEA4, these are the some markers which, if that is present in the cell, then we will say, yes, it is the pluripotent stem cells. Like that one, these markers means they are the proteins, and these proteins are transcribed from certain portion of the DNA or mRNA. So if that mRNA is present in that cells, we can say, yes, this cell is the pluripotent stem cell. We have to identify, there will be the n number of cells. After suppose 10 times I did the culture, and I want to know whether after the 10th culture that cell is stem cell or not a stem cell. So I will take one cell and I will do this analysis whether TRA160 it is present or not, or its mRNA is present or not. That is the gene expression. I will study for that one. If it is present, I will confirm, yes, at the end what product we got is the stem cell. So it is not like that we have cultured and we can directly go to the patient. Before transferring to the animal model or before transferring to the patient, we need to confirm the potency, presence of the stem cell in the cell culture. Then biological property. The pluripotent stem cells, if we give some stimulus, yes, they should have the property to differentiate and forms all the types of the cultured cells. Then human embryonic stem cells. Usually this research in India, it is one of the banned research. We are not doing this commonly. Only the trials and very controlled things are undergoing. But still, in the human, embryonic stem cells can be cultured can be collected from the IVF lab with a proper consent from the donors and the recipients. We cannot just induce all these things for our experimental sake. Only the remaining embryo. Sometimes suppose one patient comes for the in vitro fertilization treatment. For that patient, we have collected 4 ovum from the female and we have utilized only 1 ovum. She got pregnancy and everything is fine. Remaining her 3 ovums we need to discard. So with her consent, we can utilize that 3 remaining ovum with sperm for our further research. With the proper consent, we can utilize this. Obtained this embryonic stem cells, they have unlimited supply of embryonic stem cells for n number of the experiments. So once you got that inner cell mass, continuous supply, you need to just maintain the proper cell culture. They can give rise to the clinically relevant cell numbers. Initially, I told like a chemotherapy, multiple cycles are there. Here also in the stem cell, we may need repeated cycles of the stem cell therapy. For that one, we need a continuous supply of same quality of the cells, same quality. Otherwise, one patient has accepted one type of the stem cell, his body is ready. Tomorrow, we cannot inject another type of the stem cell because there will be the chances of the rejection, immunological rejection. Like in the organ transplant, we are facing the issue of the immunological rejection, organ rejection. So same thing will happen here. So the best solution, we should have the continuous supply of the cells by the cell culture. This embryonic stem cell can differentiate into the cartilage, bone, skin, nerves, gut, and respiratory lining epithelium. I have not included the complete list. maybe pancreas also can be developed, islets of Langerhans, beta cells also can be generated, depending on the stimulus and the microenvironment. If we provide the bone surface, it will get converted into the hematopoietic stem cell, depending on the micronutrients and the microenvironment what we are providing for the differentiation. The cell types which are currently in the research, nerve cells, astrocytes, oligodendrocytes can be generated easily from the embryonic stem cells. These are the successful generation with a controlled differentiation. Controlled differentiation is very important in this research. Embryonic stem cell can form easily the cancer, teratoma. They can form uncontrolled growth, that is the cancer. So these scientists have shown that they have the control over the cell differentiation when they try to differentiate into the neurons, astrocytes, oligodendrocytes, hematopoietic stem cells, then insulin producing cells, myocytes, hepatocytes, and endothelial cells. So these are commonly used in the research purpose, not in the therapeutic uses. So what is the differentiating agent? Differentiating agent is the chemical which we induce or which we utilize to convert the stem cell into a particular cell. So that is called as the differentiating agent. So this differentiating agent may be microenvironment, may be interleukin, may be depending or some chemical agent depending on the what is our requirement. Multiple agents can be utilized simultaneously. It is a very big list. I have not included here. Studies of the mammalian embryo provide clues as to how the embryonic stem cell differentiate might be controlled. So now the studies are going on more focusing to find out more differentiating agents. So this is the one zone. See, one zone is focusing on the embryonic stem cell. They want to form new organ. And one research is going on where induced pluripotent cells research is going on. Induced pluripotent stem cells. That means we will convert even adult cell into the pluripotent cell reverse. We will take the cells in the reverse direction. So research are going into different direction. One are saying no need to destroy embryo because it is prevented by the government. Okay, we will not use the embryonic stem cell. We will use the adult stem cell and we will convert it into the pluripotent stem cell. They are going to find out new type of the inducers. They are going to find out new chemicals which can convert. Have you heard lymphocyte culture? Lymphocyte is converted back into the lymphoblast using the chemical called phytohemagglutinin. It is a simple chemical which we can induce lymphocyte conversion into the lymphoblast, and that lymphoblast can break. It is very commonly used in the cytogenetic laboratory. Hematopoietic stem cells from the human embryonic stem cells. So hematopoietic stem, the culture of the embryonic stem cells on the marrow support. This earlier I told, microenvironment we can provide. If we provide the microenvironment of the that marrow stromal support, then that embryonic stem cells will get converted into CD34 plus hematopoietic precursor cells, which will ultimately form RBCs, WBCs, megakaryocytes. Currently, I am saying that embryonic stem cells are important only in the biomedical research. That is the biomedical research which are going for the basic studies in the early human embryonic development and its disorders. Then functional genomics in the human cells. These are the research there to find out the novel factors which can control the cell differentiation. Then suppose we have some embryonic stem cells. We can expose that cells to certain chemicals to test the potency of that drugs, whether they are safe during the pregnancy or they have certain bad effect. So it is not like that only the stem cells will be utilized for therapy, but they are utilized for the discovery during the drug discoveries, actually, to find out the safety of the drugs on the embryonic cells. Actually, we say that radiology radio exposure should not be there on the embryo. They produces the DNA damage. So every time we cannot expose the developing human embryo to the chemicals to find out the side effects. So these embryonic stem cells can be easily used, and it is ethically correct to use these cells to find out the toxic effects. Then transplantation medicine, this is only available in the animal model, not in the adult human models. Successful treatments of the diseases which they have done in the animal models, that severe immunodeficiency disorders, diabetes, Parkinson's, diabetes mellitus, we have developed one mice which is not having the pancreas or which is not having the insulin receptors. We have created some mice like that one which is not producing the insulin, and using the stem cell therapy, we have tried to treat such an animal model, and scientists got the success in the treatment of diabetes, Parkinson's disease, spinal injury, demyelinating disorders, and myocardial infarction. Even a portion of the heart induced, actually, these animal models are induced animal models. We will do the experiment to get the animal which is having diabetes, which is having some Parkinson's disease. We will destroy substantia nigra so that their animal will come with the Parkinson's disease. And then we will induce some embryonic stem cell there and to see the effects, whether that animal get cured or not. Such a treatments are successful in the animal models. There are certain challenges in the transplantation therapy, particularly insufficient number of the available stem cells. The stem cell finishes in 1 or 2 cycles. For the next cycles, we don't get the cells. Suppose, for example, I am going to treat the rat model, which is not having the islets of Langerhans properly. So, okay, I have given 1 cycle and now insulin level started increasing. But I am not satisfied with that insulin level. I want more stem cells to be transferred, but I don't have the stem cells. So continuous supply of the stem cells should be there. So that is the first challenge they are facing. What cell to be transplanted? Whether adult stem cell, whether pluripotent stem cells, so or embryonic stem cells. So that is also the questionable. That challenge is also there. Whether partial differentiated cells need to be transferred. So that are the certain challenges. Then delivery vehicle, how we can deliver these adult cells by the injection route, by the laparoscopic. We can just inject in the peritoneum, they will settle down in the peritoneum and they will. So delivery vehicle and the route of the delivery is also the another challenge in front of the scientist, and problems in tissue rejections. So before that one, immunosuppression, should we apply? Should we reduce the immunity of the individual? So that is also one concern. Particularly immune rejection is very common in the embryonic stem cells. But some scientists are saying that these embryonic stem cells are competent to adapt in the immunity of the individual. But some are facing the issue with the tissue rejection, actually, immune rejections. So like that one, lot of issues are there. I'm not going in detail of this one. Human cloning or the cloning of these therapeutic cells, actually, that is also one challenge they are facing. Combining the cloning methods with the embryonic stem cell technology to produce the cells which are custom made for the patient. What is that one? Actually, we can utilize the cell of the individual and we can remove the nucleus and we can implant the embryonic nucleus in the cells so that the surface of the cell will remain belonging to that customized patient. So chances of immune rejections will be less, but these are the certain difficult tasks, difficult procedures. Now coming to the adult stem cells. These adult stem cells are nothing but the tissue specific stem cells, or they are the somatic stem cells. They are specialized to some extent. For example, neuronal stem cells, if it get differentiated, it forms the progenitor cells. These progenitor cells differentiate into the neuron, oligodendrocyte and astrocyte. It cannot get converted into the blood cell. So adult stem cells are little bit differentiated. They are little bit committed towards one side. Unless and otherwise we provide certain micronutrients, it will not form the other cells. Thus, the adult stem cells are the multipotent cells. They are the multipotent cells. For example, the neuronal cells we have seen, this is the example, they differentiate into particular cells. Some scientists have discovered the plasticity property. Plasticity property means the stem cells which can converted into the tissue which is completely different from the previous tissue. For example, suppose we have the hematopoietic stem cells. We have provided to another stimulants and another micronutrients. So that hematopoietic stem cells can form the heart muscle. So this is the property of the plasticity of the stem cells. There are certain advantages of the adult stem cells. They are non-immunogenic because we have collected from the same donor. So they are non-immunogenic to that person. They are specialized to some extent, easy to procure. We can just tap the bone, we can take the bone marrow cells. So it is easy to collect. They are non-tumor. They are already committed cells. They are going to form only the blood cells and not any other cancer cells. But embryonic stem cells are not like that one. They can form any type of the cells. So they may convert into the cancer, but adult stem cells are very good. They are non-tumorigenic. If we collect even the bone marrow, there is no harm to the patient. No harm means minimal things will be there. The patient may have the pain. He may have to go under a small surgery. Of course, that will be there. But in the embryonic stem cell, we are directly destroying the entire embryo. Once we remove the inner cell mass, that embryo is going to die. So this is there. And currently, ethically, we can say this is correct. Ethically, it is permitted to work on the adult stem cells. But some drawbacks are also there. Limited quantity. We cannot remove the entire bone marrow. So we have the limited quantity of the cell supply. Difficult to obtain in certain cases. For example, I want hepatocytes, so I have to take the liver biopsy. So depends actually how we are obtaining it. Quantity, if I want a bulk quantity, it is difficult to obtain. Then mortal, we cannot keep on multiplying the hematopoietic stem cell for n number of cycles. After 35 cycles, after 50 cycles, they will lose their property of the stem cell. So that will not be utilized actually. That's why I am saying limited number of quantity. For example, for stem cell therapy, I need 4 cycles of the therapy to the patient. I can provide only 1 cycle. For the next cycle, I don't have the cells. Second cycle, okay, little bit cells are there. Because every cycle, we need to give the gap. And in that gap, I need to do the cell culture continuously. I should keep on culturing the cells, and that cell culture is not possible. Adult stem cells cannot multiply n number of times. After a certain time, they lose their stem cell property. So there are certain advantages, disadvantages, embryonic stem cell and adult stem cell. Inner cell mass, from that one we can get the embryonic stem cells and adult stem cells. Usually this is a new trend came in the society, that umbilical cord blood. Umbilical cord blood and that umbilical cord banks are there, and they are storing the umbilical blood there. We will see a little bit after this one. So that blood is commonly used as the source of the adult stem cells. The embryonic stem cells easy to get. We can just take out the inner cell mass and it is easily obtained. But in the adult, when I take out the bone marrow, instead of the stem cells, some fat cells are coming, some blood cells are coming. From that one, isolating the stem cell is a difficult task. So when I go for the culture, I need to wash and isolate the proper stem cells. I have said earlier, in the skin, there are stem cells. So how can differentiate? How can I take out that cell? It is very difficult task to isolate the stem cells in the adult body because they are surrounded by n number of normal cells, other cells. Then immunogenic, this rejection of embryonic stem cell is very common, but adult stem cells, the chances of rejection is little bit less. Embryonic stem cell collection, we need to destroy the embryo, but in the adult stem cell, we are not destroying the life. They can multiply indefinitely. Adult stem cells has a limited multiplication cycles. Embryonic stem cells, difficult to differentiate and difficult to control their differentiation, but adult stem cells, they are already committed. They can easily be differentiated into a particular things. Adult stem cells can be collected from the umbilical cord blood, then bone marrow, epithelia, dental pulp, liver, retina, pancreas and skin. These are the common sources for the stem cells. Out of that, currently bone marrow and umbilical blood, umbilical cord blood, these are only 2 commonly utilized cells as the source of stem cells. There was a scientist, I told now one reverse direction research is also going on. The Nobel Prize owner in 2012, he has discovered that induced pluripotent stem cells. So in the induced pluripotent stem cells, what he did, there is an adult stem cells, and he has given the stem cells associated gene. He has induced transcribed genes. There are certain genes like OCT4, SOX2, KLF4. So these are the genes which are there in the adult stem cell, in the stem cells. He has induced these genes into the adult cell actually, and that adult cell get converted into the pluripotent cells. So reverse direction. So this pluripotent stem cell has limited capacity. It can be converted into a particular type of the cells. So reverse direction flow can be possible. The example, simple example is lymphocyte phytoimmunoagglutinin conversion into lymphoblast. Like that one, it is the simple example. We can take the life in the reverse direction. The applications of the stem cell therapy, currently it is proved useful for the stroke, traumatic brain injury, Alzheimer's disease, Parkinson's disease. Even missing teeth can be formed, baldness, deafness, wound healing, bone marrow transplantation. These are the proven facts actually. But as per my knowledge, right now in India, bone marrow transplantation is permitted, and others are the clinical trials for which patient has to register. So these are the other applications like myocardial infarction, muscular dystrophy, diabetes, where the cells are already damaged and that can be replaced using the stem cells, thalassemia, cirrhosis of liver, severe combined immunodeficiency disorders. So these are the certain things. Out of this one, we have to focus more on the two things. One is cancer patients. The cancer patients which are treated with the chemotherapy. And second one is the aplastic anemia. These two are very commonly focused areas in the India right now. One is the cancer patient. We are giving chemotherapy. So they will have the anemia. They will have the entire the blood cells count, they will go down. And in that cases, to increase the blood count, we can go for the bone marrow transplantation. And in aplastic anemia also, we can use the bone marrow transplantation. So bone marrow stem cells are the stem cells which we have recovered from the umbilical cord that we can utilize. So currently, cord blood banks are emerging in the India. What is cord blood bank? For that one, we need to collect the cord blood actually. We can collect some quantity, 50 to 60 ml or 70 ml of the cord blood we will collect, and we will store it at the -196 degree. Cryopreservation we will do. This actually is a sensitive issue. What is the sensitive issue behind the cord blood bank? Actually, the cord blood bank, only a small quantity of blood we are storing, and these companies are making parents, they are creating fears in the parents that your daughter will have, your son will have this disorder, that disorder. You just give your blood to us, cord blood, and we will store for 21 years, 30 years like that. Is it really required? Will that kid will definitely have some disorder? The chances are very less, but they are playing with our emotions. Still, I can say that if some family history is there, if you feel that your parents or your son, one son is having some disorder, second may have, that time you just blindly go for the cord blood preservation, but it is not required for everyone here, because the cost involved is 40 to 60,000, and they may store it up to the n number of the years actually. It depends on them. So easy collection is possible. That's why we are using this umbilical cord blood. Then there is no risk to the mother and the child. That's why also it is okay. We can go with this one. Then chances of transmission of the infection is also less. Antigen typing is not required because we are collecting the cord blood and that we are utilizing for the same patient, or we are utilizing it for his brother or sister. So antigen typing is not that much required, and less chances of rejection are there. But personally, I feel that the utility of this is very low, very, very low. there are certain problems we should understand before providing our consent for the storage of umbilical blood. The problems are like very small quantity of the blood we are going to store, and for that one lot of money will be required. So it cannot be applied for the entire India. It is very difficult. Some people may think that government of India should take initiative to provide the storage of cord blood. We are facing here to deal with many other diseases. So how to tackle this issue? Very small quantity, like chemotherapy, multiple stem cell therapy cycles are required. This 50 to 70 ml of blood, how much stem cells we can provide to that individual? That is also the another issue. Then hereditary disorders cannot be treated if the patient is having certain, suppose we have seen that he is having one enzyme deficiency. Though we have stored his cord blood, that cord blood is having stem cell, but definitely that cells will also have same disorder what that boy is having. So for hereditary disorders, we cannot utilize their stem cell. Then storage is also another big issue, because minus 196 degrees centigrade temperature, cryopreservation for continuous 21 years. That is also the another issue. The quality of the storage is the issue actually. There are certain issues. The companies, they don't tell us properly. There are a lot of organizations which are storing the blood, but there that all cord blood banks in the India, they are under control of Central Drug Standard Controlling Organization, and they should get the permission. In India, only as per my knowledge till date, only one government is having this one, that is the cord blood bank, government of that Kolkata. West Bengal government has the government bank, but others are the private. In Mumbai also there are many are there, in Bangalore, Chennai, all metros are having this cord blood banks, and they are providing the facility. Of course, they are not, I am not saying they are doing something wrong, but we have to take a call whether we should go, we should advise for the entire society. We have to see the poverty of the patient. Based on that only, we should give the suggestions. So marrow stem cells, they are the properly utilized in the India. Marrow, you just today focus, others where the research area, and this is the treatment area. That is the marrow stem cells, bone marrow stem cells. Yes, of course we can collect, and that we can provide to the next. Even we can multiply them outside the body for 50 to 80 population doublings, and that we can utilize for the stem cell therapy for the mesoderm, neuroectoderm, and endodermal derivatives. Yes, of course, that also one small zone of the research area. But you can utilize for the aplastic anemia and the cancer patients which we are suffering from the chemotherapy, immunosuppression. Okay, this nuclear transfer, to avoid the rejection, immunorejections, nuclear transfer is the another things actually. Embryonic stem cell lines created from the patients with a certain diseases to study the disease development and to develop the drugs. This is also the research area where we are using the nuclear transfer, but it is the lessly applicable area. These are the stem cell therapy centers. I am not going in detail of this one. The Rajiv Gandhi Cancer Institute and Research Center in Delhi, then AIIMS Delhi, Tata Memorial Hospital in Mumbai, Majumdar Shaw Cancer Center in Bangalore, Apollo Hospitals in Chennai. These are the certain agencies. Other than that one emerging is Advanced Cell. It is a private institute or the private agency which have got the government permission to provide the stem cell therapy to the patients, and they have treated a huge quantity, more than 8,000 patients. This Advanced Cell from Delhi, Noida, they have treated more than 8,000 patients, and mostly they are the foreign patients because of cost involved in the stem cell therapy. Now the main concern is the research area or the stem cell therapy. It is under control of the government. All the clinical trials are under control of National Guideline for the Stem Cell Therapy in 2017. These are the guidelines actually that need to be followed. Each institute should have their own society or committee, like institutional ethical committee is there. If the institute is proposing any proposal for stem cell therapy, or stem cell research, they need to formulate one committee, that is the institutional committee for stem cell research. If they don't have, they need to formulate this committee. Committee approval will be required, ethical committee approval, animal, if we are proposing the animal study in the stem cell, that research approval should be there. And after that, we have to submit the proposal to the National Apex Committee for Stem Cell Research and Therapy. If that committee approves, then only we can go for the stem cell therapy and stem cell research. The permitted area is also there in the India. Particularly, there is no need to get any permission to start the bone marrow transplantation in the patients. That is not needed. That permission is not needed from this apex body, because stem cell therapy is the routine part for the cancer patient. So it is not like that stem cell therapy for the cancer or bone marrow transplantation we are doing, hematopoietic stem cell therapy. So that permission is not required. Only oncologist is sufficient, or transfusion medicine unit is sufficient to establish that facilities in the institute. Some are the prohibited area in the India. Germline gene therapy and reproductive cloning is prohibited. Lot of things are there in our mind. Movies are producing lot of chaos in young generation, particularly I'm talking. Don't see that science fiction movies for the stem cell therapy. They can clone anything. They can clone the animal. So we have to be little bit careful what is actually happening, because see, germ cell therapy and these things are banned in India. Our government is not permitting. In future they may permit. Right now it is not there. Okay, in vitro culture of intact human embryo, regardless of the method of their derivation, beyond 14 days of the fertilization or formation of the primitive stick, whichever earlier, beyond that, means once you have fertilized, before 14 days, you have to finish all your experiments. Otherwise, that embryo may get generated, and after that one, you are going to kill the human being. It is not permitted. Okay, then research involving the implantation of the human embryos. You have derived one embryo with the stem cell therapy, and now you want to implant that embryo. No, it is not permitted. You cannot modulate any embryonic cell, human embryonic or animal embryonic. You cannot do that one. Breeding of an animal in which any type of the human stem cell have been introduced at any stage of the development are likely to continue to chimeric gonadal cells, which means we may produce one animal, scientist may produce one animal which is having some human cells and animal cells. That such a type of research is not permitted. So these are certain prohibitions, laws and regulations in the India regarding the stem cell. So take home message, currently we can treat our cancer patients and aplastic anemia patients easily using the stem cells. That is the therapy available. Others are clinical trials. If some patient wants to get benefit of that one patient thinks that, okay, I'm going to die before that one, I want to try this one. Yes, of course, they can register in the clinical trials. Whatever ongoing clinical trials are there, they can register and they can get benefited. But other than that one, it is prohibited. So that's all regarding the stem cell. Thank you.
This was indeed a fantastic treat for all of us, isn't it? Thank you, Dr. Sontake sir, for such an amazing clinical and legal insight to stem cells. I request you all to please fill the post-test Google form shared on the group, since it is mandatory for MMC certification and credit points. I now call upon Dr. Shubhangi Muthial, Joint Organizing Secretary, to propose a vote of thanks to all who have contributed to the success of this year. Thank you.
Dr. Nagaraj P, we will present a memento to the Dr. Yogesh Sontake, sir. I would like to take this opportunity to express my gratitude to each and everyone who has contributed to the success of this event. First and foremost, on behalf of Department of Anatomy, I would like to thank our Dean, Dr. Praveen Rathi sir, for giving us an opportunity and permission to conduct the CME. Thank you very much, sir. I would also like to express deep and heartfelt gratitude to late Dr. Manu Kothari sir for being an inspiration behind the concept and theme for this CME. May his soul rest in eternal peace. My sincere thanks to all the speakers, and especially Dr. Yogesh Sontake sir, who has graced this CME by his physical presence and shared his knowledge with us. Last but not the least, I thank all the delegates and participants without whom the success of this event would not have been possible. Thank you all for the overwhelming responses. And one important announcement, your MMC point certificate we will give you in the mail form within 2 months, and your points will be reflected in your MMC account within 1 month. So don't send any message on the WhatsApp group. So this CME is now declared over. 1 minute, 1 minute. We take a leave for now with the promise to come back next year with an equally interesting topic, which will be announced later. And one more important announcement, we have arranged tea and coffee in the physiology lab for faculty only. Thank you. Thank you.